Light Radha antunna. Okay. Yeah, good afternoon. This is Dr. Vinila. I'll be chairing the session. Thank you so much for this opportunity. The speaker for today is Dr. Priyanka P. Kambal, Assistant Professor, JMF ACPM Dental College and Hospital, Dhule, Maharashtra, India. Her topic will be prognostic role of microRNA in oral squamous cell carcinoma, a systematic review and meta-analysis. Hi, Priyanka. Hope you enjoy the session. Let's start. You're not audible, Ma?
Yeah, I'm audible now?
You're perfectly audible.
Yeah, very good afternoon to one and all. Myself, Dr. Priyanka Prakash Kamble, Assistant Professor from JMF ACPM Dental College and Hospital, Dhule, Maharashtra, India. I would like to thank the organizers of the UCG conferences for giving me this opportunity to present my study. So to start with my presentation, the topic of my presentation is the prognostic role of microRNA in oral squamous cell carcinoma, a systematic review and meta-analysis. Oral squamous cell carcinoma accounts for about 90% of the oral cancers and is the cancer with the highest incidence rate in the head and neck region. Oral cancer consists of the malignant neoplasms arising from the lips, hard palate, upper and lower alveolar ridges, sublingual region, buccal mucosa, anterior two-thirds of the tongue, retromolar trigone, and the floor of the mouth. So this is a diagrammatic representation of the two graphs where these are the reports from the Globocon 2020, the recent reports, where the first graph is showing the incidence of lip and oral cavity cancers in the various parts of the world, where we can see the highest incidence can be seen in the part in Melanesia, followed by the South Central Asia, where the incidence rate is around 13.3 in males and 4.6 in females, followed by the least in the Central America, where you can see the highest incidence rate in South Central Asia, emphasizing more in areas of Pakistan, Sri Lanka, and India. Here in the second diagrammatic representation, where we can see India is having the most number of mortality rates due to the cancer in men because of the oral cancer. So these are the statistics we can see from the Globocon 2020 report. Next. So the current treatment modalities for oral cancer include surgery, radiation, chemotherapy, and immunotherapy. Still, the 5-year survival rate of oral squamous cell carcinoma remains less than 60% due to late-stage diagnosis, high rate of recurrence, and metastasis to locoregional lymph nodes. So here's a certain risk factors which we have enumerating related to the oral carcinogenesis, which can be broadly classified into environmental factors, genetic factors, age, and epigenetic factors. So the main risk factors, which includes most commonly seen in India, is betel quid chewing, tobacco chewing, alcohol, and other environmental factors, and the other infections like viral infections, including HPV and EB, are the major causative factors or the risk factors of oral cancer. So oral cancer is regarded as a multifactorial disease that is thought to be the result of various genetic modifications that includes the activation of oncogenes and silencing of the tumor suppressor genes. Epigenetic regulation is evaluated as an early event in the process of oral cancer development. Epigenetic modifications include hypermethylation in the promoter regions of the gene, post-translational histone modification, and post-transcriptional regulation by the microRNAs. So here is a basic schematic diagrammatic representation of the microRNA biogenesis and its function. Here, the microRNA are transcribed from the DNA into the primary RNA by the RNA polymerase. 2. The long primary microRNA is processed by DROSHA and DGCR8 to generate a pre-microRNA and is processed to generate, and then it is again exported from the nucleus with the help of exportin 5. Okay, so then these from when they are transported from the DNA to the cytoplasm, it is trimmed into short double-stranded microRNAs by dicer. A single strand of mature microRNA is incorporated along with the argonaute proteins into the RNA-induced lysine complex, which binds to the target mRNA, leading to either mRNA degradation or translational regression. So dysregulation or any increase or decrease in the microRNA expression causes the oncogene activation or tumor suppression gene expression, leading to carcinogenesis. So this is again a very nice diagrammatic representation given by Ostan et al. In 2021, where they have given in the diagram 1A, they're showing that the downregulation of a tumor suppressor microRNA results in the increased expression of oncogenes and further to elevated levels of tumor promoting proteins, leading to the increased carcinogenesis. While in diagram B, they're showing that upregulation of these oncogenic microRNAs lead to the repression of the tumor suppressor genes expression and reduce expression of these tumor suppressor proteins, then further promoting carcinogenesis. So therefore, microRNA can be capable of offering a sensitive method for oral cancer detection, monitoring, and prognosis. Hence, the objective of the systematic review was to elucidate the significance of specific microRNA in oral squamous cell carcinoma prognosis. Additionally, comprehensive meta-analysis was performed to investigate the significance of microRNA in determining patient prognosis with subgroup analysis, further exploring the prognostic significance of frequently expressed microRNAs. So the aim of my study was to identify the potential microRNA which have a prognostic role in oral squamous cell carcinoma, to evaluate and alter the altered expression of these microRNAs in oral squamous cell carcinoma. The review questions are as follows, that is, what are the various microRNAs involved in oral squamous cell carcinoma? What are the significantly expressed microRNAs in oral squamous cell carcinoma? And microRNAs can potentially, which microRNAs which can potentially have a utility as prognostic biomarkers in oral squamous cell carcinoma. So when it comes to methodology, search strategy and study selection, that is the preferred reporting items for systematic review and meta-analysis, that is the PRISMA guidelines were followed. The databases used includes Google Scholar, PubMed, Scopus, Embase, EBSCOhost, and Science Direct. The keywords used were microRNA, oral cancer, the head and neck squamous cell carcinoma, biomarkers, microRNA expression, upregulation, downregulation, and deregulation. Literature search was done from January 2009 to December 2022. Data extraction was done by independent 3 reviewers using Microsoft Excel sheets. Predefined search strings were generated using these keywords, which includes name of the first author, year of the publication, the country, number of participants, the methodologies, microRNA studied, types of samples, which include tissue, serum, saliva, plasma, and cell lines, dysregulated microRNAs, expression, which includes high and low expression, prognosis, regional metastasis, and significance. So for the quality assessment, we included this checklist called as Dutch Cochrane Center, represented by Moose for the epidemiological studies. And we divided into sub 4 categories. That is the criteria we have selected, which includes a clear definition of the outcome of the assessment, which the studies which are having the particular outcome, that is overall survival and the disease-free survival, the clear definition of the measurement of the microRNA, whether they are quantitatively the various assays which they are using, that is RT-PCR, in situ hybridization, cell cultures, genotyping, all that has to be clearly mentioned. Clear-cut definition of the anatomical sites and the clear definition of the population, or rather that is a country. So this was a tables which we followed, out of which we have categorized these criteria. So those studies which fulfill all these criteria were considered in the group studies, where we can see the maximum of the studies were in the criteria for a good this thing, while very few one unsatisfactory study was included, was excluded rather. These are the inclusion and exclusion criteria. The inclusion criteria includes the studies which describe the microRNA expression in OSCC patients, those investigating the expression as well as the patient survival, and the microRNA consisting of various samples like serum, saliva, plasma, and in OSCC patients. The methods used for the microRNA expressions will include quantitative as well as qualitative studies assessing the survival data. So those studies which having the survival data were also included in the studies. Excluded articles includes the conference abstract, reviews, correspondence to letters to the editors, then in vitro or in silico or animal studies were excluded. Studies that were conducted as a part of thesis or incomplete studies were excluded. Non-English articles and the articles which includes precancerous lesions or the metastatic cancer and other carcinomas were totally excluded from this study. So this is a Prisma flowchart where we are showing a Prisma flowchart where we are seeing 31,915 and potentially eligible studies were identified in the database search, while 31,815 were excluded due to the irrelevant topics. 104 were identified for screening, while 34 articles were excluded for the reviews, in which include review, report to the letters and editors. 70 were checked for the inclusion and exclusion criteria, where 20 were excluded after the full screening of the text articles. And finally, 50 reviewed for in-depth analysis and conducting the study. So these are the descriptive characteristics related to the data were included in the studies. We have analyzed it in the form of the author's name, where we can see 50 studies were totally included in the systematic review, and we found 12 countries. This systematic review was originated from 12 countries, which include China, Japan, Taiwan, Korea, Brazil, New York, Germany, and the maximum numbers of studies were seen from China, Japan, and Taiwan, where we can also see various samples, that is tissue, cell lines were used. Maximum were tissue as well as the cell lines. The methodology which was used is the qRT-PCR, followed by the immunofluorescence, the ELISA, Western blot. Various microRNAs were studied in the descriptive analysis, while the tissues, cell lines were included in the study, and very few articles from saliva and plasma were seen. The follow-up was done from 3 months to a maximum of 9 years, and the favorable prognosis was also evaluated with the expression of these microRNAs. So this is a diagrammatic this is a representation where we can see the percentage of microRNA, where we can see 39% of microRNAs were upregulated, while 61% of microRNAs were downregulated. We also showed, we studied the microRNAs with their significance. So what are the various significance of these particular microRNA in the process of carcinogenesis, or how they are acting, whether the tumor suppressor or oncogenes, all that also was studied in the descriptive analysis. So these are the different microRNAs which were studied in the systematic review. So upregulated microRNAs which are frequently seen was microRNA 21, microRNA 155, microRNA from systematic review, and these highlighted microRNAs were frequently seen in many articles. So we did meta-analysis on 36 studies where we collected these 36 studies only based on the survival analysis. So those studies were having the analysis, survival analysis, that is a disease-free or this overall survival analysis using Kaplan-Meier's curve. Those studies were included in the meta-analysis using our software. A random effect model used for survival analysis, that is the overall survival rate and disease-free survival rate. Final data was reported as a pooled hazard ratio with 95% of confidence interval from the Kaplan-Meier's curve for outcomes, that is a primary outcome, and the secondary outcome, that is the disease-free survival. So we had a primary outcome, that is overall survival, and secondary outcome, that is a disease-free survival. The visual representation of the data was done using the forest plot. The heterogeneity was evaluated plot and Beggs and Majumdar rank correlation test. P-value less than 0.01 indicates statistical significance. The subgroup analysis, that is microRNA, most frequently represented in the selected pool of studies were included in the meta-analysis. So this particular forest plots shows the overall survival rate of microRNA, where the 26 studies were included in the 26 microRNAs were included. The studies were done with the overall survival rate, the hazard ratio, which is around 1.87. Here you can see the entire, all the studies were showing the favoring the death, while the studies which include Lee et al. In 2015, Varnania et al. In 2017, Jin et al. In 2019, and Jacob et al. In 2019 showed showed favoring survival. So there was a heterogeneous data which related to the forest plot, and the p-value, the results were statistically significant rather, and the I-square statistic was around 82%. Here in the funnel plot also, we can see the 26 study. In the funnel, we can see very few articles inside the funnel, but there are very few, there are many articles which are outside the funnel, which shows that the data is quite heterogeneous because of few studies which are included in the microRNAs due to the variability in their assessment or any kind of a difference in their sample sizes. So this is a funnel plot of the 26 studies showing the microRNAs with overall survival having the large number of heterogeneity. So disease-free survival rate of microRNA was studied using 11 studies. So the 11 studies showed favoring a death, which includes the hazard ratio of 1.79 with I-square statistics around 66%, and the results were statistically significant, that is p-value less than 0.01. Here in the funnel plot also we can see the 11 articles which were included in the funnel plot. Only one article was not in accordance with the results which are shown. Next, the upregulated microRNA with the overall survival. So the upregulated, the very articles like 16 studies were included in the this particular forest plot, where showed upregulated microRNA for overall survival. All the articles excluding the Lee studies by Lee et al. In 2015, Barnenia et al. In 2017, and Jacob et al. In 2019 showed a favoring survival. So the hazard ratio for all the studies carried out is 1.69, while the I-square statistics around 78% with p-value 0.01%. The downregulated microRNA with overall survival showed many articles except the Jin et al. In 2019 showed a survival, showed favoring the survival, while the other articles, 9 articles showed favoring the death, which showed that the hazard ratio was around 1.96 with I-square statistics about 85%, and the results were statistically significant. So we also did the subgroup analysis of all the microRNA which was frequently expressed in the studies. So first we did the overall survival analysis of microRNA 21, which includes 5 articles which showed the survival analysis with a hazard ratio of 1.79 with I-square statistics of 77%, and the p-value of the results is statistically significant. So the disease-free survival of the microRNA 21, which include 2 articles, showed hazard ratio of very high hazard ratio, that is 2.07, but the results were statistically non-significant. So microRNA 375 was also analyzed for the overall survival, which include 2 studies which favors a death with a hazard ratio of 4.16, which was on a higher side, with p-value less than 0.01, which showed a statistically significant analysis with I-square statistic around 86%. The microRNA 100 with overall survival was also included in the study, which showed hazard ratio of 1.72 with I-square statistic of 45%, but no statistically significant results were obtained from the 2 articles. So to discuss, the aberrant expression of microRNA has been demonstrated to be significantly associated with the poor prognosis of the oral cancer using survival analysis, which is also in concordance with the study carried out by the Jamali et al., where he also studied various microRNAs subgroup analysis and done the meta-analysis of few frequently expressed microRNAs head and neck cancer. Dysregulation and differential expression of microRNA could be caused by the multiple mechanisms, including amplification or deletion of the microRNA genes, abnormal transcriptional control of microRNAs, dysregulated epigenetic changes and defects in microRNA biogenesis machinery. The pooled hazard ratio for overall survival of up and down regulated microRNAs was around 1.84, while for the disease-free survival was around 1.79, stating that oral cancer has a lower probability of disease-free survival. The pooled hazard ratio for upregulated microRNA for overall survival was 1.69, while for downregulated microRNAs was 1.96, thus concluding that the risk of the death was higher in downregulated microRNAs. Overall, this systematic review highlights microRNA 21, 99A, 125B, 155, 205, 1246, and 375 and 100, which may have a potential for clinical use as a prognostic marker in oral squamous cell carcinoma, which was in concordance with the study carried out by the Kumaraswamy et al. In 2019. MicroRNA 21 and 375 offer great potential for prognostic markers in oral cancers, having significant hazard ratio values with overall survival and effect sizes indicating higher power of prognosis. MicroRNA 100 have effect sizes that are non-significant, implies that it has low power of detection, may not be used as a prognostic marker. So the limitations of the study were the major issue highlighted in this study is the inconsistent findings between the studies and the data sets, despite the common aim to identify prognostic microRNA biomarkers in OSCC. Each microRNA measures various aspects of the cancer in different anatomical locations and refers to the inconsistency in various testing methods. Therefore, variability in reliability and validating testing makes it difficult to compare the different studies. The meta-analysis was conducted using a hazard ratio and 95% confidence interval values extracted from the Kaplan-Meier's curve, which requires approximations to be done, thus introducing errors. So the future considerations include the main challenge, which I feel is to identify the critical targets of microRNA involved in the cancer and establish their contribution to the malignant transformation. Research prospects in circulating microRNA detection and analysis may pave way to development of novel minimally invasive or non-invasive cancer biomarkers. However, more efforts are still needed to screen microRNA candidates by deep sequencing and validate them as a diagnostic and prognostic biomarker in a large cohort of patient samples. To conclude, different altered microRNAs have been proved to play key roles in the initiation and progression of oral cancer due to their roles either as an oncogenes or a tumor suppressor gene. They have also considered potential to be excellent biomarkers and new therapeutic tools for this pathology. Major efforts are needed to establish whether one or more microRNA must be targeted for sustained tumor regression, and if in such a strategy can be used as a monotherapy or as an adjuvant therapeutic approach. So these are my references. Thank you.
Thank you so much, Priyanka. It was a very sincere, elaborate, and a wonderful presentation. Your presentation shows a lot of work you have done.
Thank you.
I just wanted to ask you one question.
Yes, ma'am.
Does the same apply to any other, because squamous cell carcinoma anywhere in the body is the same we see. Adenocarcinomas, they keep changing in the body. So can this be
Yes, ma'am.
applied to anywhere else, not only to oral cancers? Can it be applied anywhere else? This concept can be applied anywhere else of the squamous cell carcinoma with the microRNA technology?
Yes, ma'am, we can use it in anywhere we can use. We are seeing various cancers, breast cancers and pancreatic cancer. They are trying to find out, because there are the certain since oral cancer is a multifactorial, where we can see a large number of microRNA which are altered, which the scenario might change for other types of cancer. Maybe there's a certain cancer, certain microRNA may remain similar to the other cancer types also. So it can be applied to any cancer type, ma'am, this particular approach.
Thank you so much. That was wonderful. Anybody else would like to have some questions for her? I think nobody wants to have questions. Thank you so much, Priyanka. It was really nice to have you on this, and we really enjoyed your session. Have a good day, Ma. Thank you. Yeah.
Thank you. Yeah.
The next speaker for today is from India, Dr. Shweta Kark. She's a pathologist and who would be speaking about a case report of previous lower segment cesarean section scar endometriosis. Dr. Shweta, the stage is yours. Dr. Shweta, are you available? I think Dr. Shweta isn't available right now. Can we go with the next speaker? We'll just wait for 2 minutes. If Dr. Shweta is not responding, then Dr. Ritu, please be ready. Thank you. Okay. As Dr. Shweta Garg is not available, I would like to call upon Dr. Ritu Sarkar from India, working in Silchar Medical College and Hospital, Kachar, Assam, India. She's going to speak about expression of cyclin D1 in various endometrial pathologies. Dr. Ritu, the stage is yours.
Good afternoon, everyone. Thank you for giving me this opportunity to present before you all. So, I'm myself, Dr. Ritu Sarkar. I am a third-year resident pathologist in Silchar Medical College, Assam. I'm from India. And today I'm going to present a topic which I have done research on in my college. That is the expression of cyclin D1 in various endometrial pathologies. Ma'am, is my screen visible to everyone? Am I audible?
Yes, ma'am, you're audible.
And ma'am, what about my presentation?
Yes, it's visible.
Okay. So, as we know, endometrial carcinoma, nowadays it is the fourth most common malignancy in females after breast, bowel, and lung cancer. It generally develops from the endometrial epithelial lining of the uterine corpus, and it most commonly affects the elderly women. Almost 80% of them are menopausal at the time of diagnosis. And in the recent years, its incidence has increased over the last 10 years, and now it poses a very serious threat to the public health, especially in the females. So coming to the cyclin D1, the cyclins are the crucial proteins which regulates the cell cycle during the G1 to S phase transition. The proliferation, differentiation, and the transcriptional control all depend on the function of cyclin D1. Thus, whenever any aberrant expression of these protein occurs, it has been associated with the development of various carcinoma. So recent investigation also has found that the cyclin D1 derailment and increased cellular proliferation causes the endometrial hyperplasia to progress to endometrial cancer. So the aim of my study was to study the expression of cyclin D1 in various from normal to hyperplastic to neoplastic endometrium, and also to correlate the expression of cyclin D1 in the various pathologies of the endometrium. Coming to the material and method, I did a 1-year prospective study in my college, and a total of 79 patients were taken who were admitted into various departments, especially OBG, and who were already diagnosed histopathologically. I conducted the study on those, and then IHC was done on those cases. The inclusion criteria included patients above 20 years of age attending or admitted to the Department of OBG and who were operated, biopsied, or subsequently presented as endometrial pathologies. And excluded less than 20 years patients were excluded from the study, and also the patient who were receiving the hormonal therapy, chemotherapy, or any other kind of radiotherapy. The H&E stained section slides and the representative blocks were retrieved from the archives of the Department of Pathology. 3 micrometer sections were made, and IHC immunohistochemistry was done with cyclin D1 antibody. And also, along with that, clinical history was collected from patients along with relevant investigation as per the pro forma enclosed, including the sex, age, menstrual status, and the type of biopsy. Now, immunoscoring of cyclin D1 was done on the basis of the intensity and extent of the nuclear positivity. Because of the reactions heterogeneity, the region with the highest amount of nuclear staining was chosen, and under 40x magnification, the number of positively stained nuclei in 1000 glandular cells were counted, and the results were based on the percentage of the stained cells. So the scoring was done as If less than 10% nucleus was stained, it was graded as 0, 11 to 30% as 1+, 31 to 60% as 2+, and 61 to 100% as 3+. And SPSS 2020 version software was used for statistical analysis, and a variable of p-value less than 0.05 was taken as statistically significant. These are the number of cases and in the different histomorphological categories, where normal endometrial 36 cases were taken, hyperplastic 20, and neoplastic 23 cases were taken. And it's comprised of 45.6% of normal, 25.3% of hyperplastic, and 29.1% of neoplastic cases. So the age distribution in the normal endometrium ranged from 31 to 40 years mainly, followed by age group of 41 to 50 years, which is not of much significance in our study. And the age distribution of the hyperplastic endometrium, the patient which generally came with the signs and symptoms of the endometrial pathologies mostly consisted of age group between 21 to 70 years, with the mean age for endometrial hyperplasia without atypia was 43 years, while mean age for atypical hyperplasia was 50 years. So the most common age group for hyperplastic endometrium is 41 to 50 years, followed by age group of 31 to 40 years. Also, in the neoplastic endometrium, the age distribution ranged from 21 to 70 years. The mean age for endometrium polyp was 43 years, while the mean age for endometrial carcinoma was 46 years. The most common age group for neoplastic endometrium is 31 to 40 years, followed by 41 to 50 years. The menopausal status, which is one of the important factors in the endometrial pathologies, in which was considered, among the 20 cases of hyperplastic endometrium, more number of premenopausal cases were in endometrial hyperplasia without atypia, while among the postmenopausal cases, more number of cases included in the atypical hyperplasia. And similarly, in the neoplastic cases, 71.42% of premenopausal cases and 77.77% of postmenopausal cases comprised of endometrial polyps only when compared to the endometrial carcinoma. Parity, which is another factor in endometrial hyperplasia without atypia, maximum patients were of low parity, and atypical hyperplasia cases were highest in multiparous and grand multiparous. When compared to the endometrial carcinoma, which is a very important, interesting finding, the majority of the patients were of either low parity or nulliparous, which fall into the category of endometrial carcinoma. These are the IHC pictures which I have enclosed, showing the cyclin D1 positivity, very low and weak reactive positivity with proliferating normal endometrium. This is in the range of 11 to 31% with endometrial hyperplasia without atypia. This is a case showing cyclin D1 positivity with atypical hyperplasia, showing 31 to 60% nuclear positivity. And this is a case of endometrial carcinoma showing 61 to 100% nuclear positivity. So coming to the results, out of the 12 cases of endometrial hyperplasia without atypia, we saw that maximum number of cases were showed less than 10% nuclear positivity and were in the group of score 0. And maximum then the number of 3 cases were in the group of 11 to 30% nuclear positivity, and only 1 case was in the group of 31 to 60%. And contrary to the atypical hyperplasia, maximum number of cases out of 4 out of 8 were in the group of 11 to 30% nuclear positivity, with 2 cases in 31 to 60 and 1 cases respectively in 61 to 100% and less than 10%. Therefore, in 12 cases of the endometrial hyperplasia without atypia, cyclin D1 expression varied from 5% to 40%, with median expression of 10%. And in 8 cases of atypical hyperplasia, cyclin D1 expression varied from 10% to 80%, with median expression of 22.5%. For cyclin D1, more than 30%, as we already discussed, nuclear staining was seen in 8.33% of the endometrial hyperplasia without atypia and 25% of atypical hyperplasia, whereas 10% nuclear staining was seen in 66.66 cases and 33.33 cases respectively. Coming to the neoplastic cases, in the polyps, maximum almost 7 out of 17 cases, they showed less than 10% nuclear reactivity. However, the 3 cases out of 6 neoplastic endometrial carcinoma, they showed reactivity in the range of 61 to 100%. And then followed by 2 cases in 31 to 60% and 1 case in 11 to 30%. And however, there was no case in they're showing less than 10% nuclear positivity. Thus, the median expression of cyclin D1 in endometrial carcinoma was 60% with minimum expression of 20% and maximum of 80%. And in cases of endometrial polyp, the expression ranged from 5 to 80% with a median of only 15%. In cyclin D1 also, the 29.4% of endometrial polyp and 83.33% endometrial carcinoma showed more than 30% of nuclear staining, and less than 10% nuclear staining was seen in 41.17% of endometrial polyp and no cases of endometrial carcinoma. On comparison of the immunoreactivity of cyclin D1 between two groups, we saw that there was a significant p-value was found between comparing the endometrial carcinoma and endometrial polyp, that is 0.0069, endometrial carcinoma and endometrial hyperplasia without atypia, that is 0.0023, and atypical hyperplasia and endometrial hyperplasia without atypia, that is 0.0141. However, there was no significant p-value was seen between endometrial carcinoma and atypical hyperplasia, atypical hyperplasia and endometrial polyp, endometrial hyperplasia without atypia and endometrial polyp. So, coming to discussion, in this present study, it is revealed that the expression of cyclin D1 mildly increases to a median of 10% in normal proliferative endometrium compared to a median of 8% in secretory and no significant expression in the atrophic endometrium. In the hyperplastic endometrium, the significant expression of cyclin D1 was seen in atypical hyperplasia with median of 22.5% compared to the endometrial hyperplasia without atypia with only 10% median expression. And in the neoplastic endometrium, the expression of cyclin D1 significantly increased from expression with only 15% median in the endometrial polyp to 60% in the endometrial carcinoma. These are a few of the similar studies which have done the study on cyclin D1 in endometrium. The S. Ozuzil et al. They found that between the proliferative endometrium and cancer, as well as between simple hyperplasia and adenocarcinoma, a statistically significant difference in cyclin D1 immunoreactivity was discovered. And in the study by P.R. Kundu and A. Sindhu, they also found that in comparison to normal endometrial hyperplastic endometrium, they showed a substantial increase in cyclin D1 expression. Additionally, complicated hyperplasia displayed the highest level of cyclin D1 positivity. In a study by M. Chaudhary and S. Bansal et al., a significant difference was found between simple hyperplasia and endometrial carcinoma in terms of cyclin D1 immunopositivity. Liang S. And K. Mu et al. They showed that the exception of the endometrial serous carcinoma, the expression of cyclin D1 increased in the following order: that is simple hyperplasia, complex hyperplasia, endometrioid carcinoma, clear cell carcinoma. However, statistical comparison between these types revealed no statistical significance. And Chebra, Sia and Ghosh et al. In 2015. They also revealed that expression of cyclin D1 progressively increased from a median 10% in normal proliferative endometrium and simple hyperplasia to a median of 20%. 20% complex hyperplasia to 30% median expression in atypical hyperplasia to highest 40% median expression in endometrial carcinoma, which was statistically significant, similar to our study. And similarly, S. Masood et al. In 11 out of 25 patients with malignant endometrial lesions showed overexpression of cyclin D1, and cyclin D1 overexpression was detected in 66.66% of cases of endometrial hyperplasia with atypia and 50% of cases of endometrial hyperplasia without atypia. So the above studies suggest the expression of cyclin D1 in endometrium increased from normal hyperplastic to endometrial carcinoma with highest expression, which is also in concordance with our study. So from our study, we concluded that the overexpression of cyclin D1 increased from normal endometrium to hyperplasia and carcinoma, suggesting that it may play a role in endometrial carcinogenesis. And our findings also suggest that cyclin D1 expression of more than 30% may indicate atypical hyperplasia, while more than 60% of cyclin D1 in the same may indicate endometrial carcinoma. Also, our findings also support the significance of atypical hyperplasia as a precancerous lesion and the assumption that hyperplasia without atypia may not be a precancerous lesion. Thus, cyclin D1 may therefore be used as a useful indicator for identifying the subsets of lesion that may be precancerous and amenable to early surgical therapy, while simultaneously excluding the lesion that would be amenable to hormone therapy. And so they may be helpful in some cases as a supplement in classifying these lesions. These are my references. Thank you so much.
Thank you so much, Dr. Ritu. It was a very good, elaborate presentation. One of the member had a question for you. Doctor, which score for cyclin D1 expression can they use it for prostatic adenocarcinoma? They just wanted to know which is the scoring system they can use for cyclin D1 expression in prostatic adenocarcinoma.
Ma'am, I have to look into it actually.
Okay.
I'll reply in the chat later on. I have to see later. I'm not sure. I know just little bit. Later I'll do.
Okay. Okay. Anybody else would like to question her? Thank you so much, Ritu. It was a nice presentation, a really elaborate thing, but you did a wonderful job being a resident. Yeah. Thank you so much.
Thank you, ma'am.
Yeah. I now call upon Dr. Shweta Garg from India. She's a pathologist who will be talking about a case report of previous lower segment cesarean section scar endometriosis. Dr. Shweta, the stage is yours.
Good afternoon. Thank you for this opportunity. I am a practicing consultant pathologist at one of the government hospitals in MP. I am going to present a clinical case of a previous LSTS scar endometriosis diagnosed by me. So, in brief, the introduction, what is endometriosis? Endometriosis is a sex hormone dependent gynecological disease characterized by the growth of the endometrial tissue outside the uterine cavity. Scar endometriosis is a type of abdominal wall endometriosis that develops after LSTS, lower segment cesarean section. Now, the symptoms of endometriosis, especially the scar endometriosis, may include pelvic pain, dysmenorrhea, menorrhagia, intermenstrual bleeding, dyspareunia, discomfort with bowel movements, lower back pain during the menstrual cycle. Now, coming to the case profile and history. Now, the patient was 23 years old female. She came to me with the presenting complaints of firm swelling at the site of incision from a previous LSTS, which was done 4 years ago. The patient was referred by a surgeon for FNSC of a lump on abdomen. Her obstetric history is as follows. She was gravida 2 and para 2. The first child was delivered 4 years back with LSTS, and the second child was delivered via normal vaginal delivery.
Shweta, sorry to interrupt you. Your presentation has not been seen. Can you please share your presentation?
Just a minute, ma'am. Just a minute, ma'am. I had uploaded it. Presentation maybe.
We can hear you and see you, but we can't see your presentation.
Uh, I don't know, ma'am, why it's not
Dr.
visible.
Shweta, I'll share your I'll share your slide. Could you please guide me by saying next?
Okay, ma'am. Yeah. Yes, ma'am. Okay, ma'am.
अरे भाई बस स्क्रॉल कर दो इन
Next, ma'am. Next slide is of the introduction, which I have already told about. Now, next slide is of the case profile and history, which also I have told about. And now, ma'am, coming to the examination slide, the general examination of the patient. The general examination of the patient was within normal limit. Now, on systemic examination, per abdomen examination, I found a lump, a firm nodular lump of size about 2.8 into 1.7 centimeter at the site of the LSCS incision scar, and that this lump began to be felt by the patient 6 months after her LSCS was done. And she told me that the tenderness at the site used to increase with the menstruation. Now, ma'am, next slide is of the investigations of the patient, which were advised by the surgeon. The surgeon advised the following investigations, all the routine blood investigations, including the hemoglobin, HIV, HbS antigen, VDRL, the blood sugar, and the urine examination. All the blood tests were within normal limit, and the surgeon also advised the FNAC of the lump. I did the FNAC, and the size I already told what was the measurement of the lump, and on aspiration the aspirate was blood mix, and I stained the slides, and the HNE staining of the slides was done, and the smears showed clusters and sheets of uniform looking round to ovoid cells with scanty cytoplasm. Sorry that the cytological slides are not here, but okay. Uh, so, on FNAC, I made the diagnosis of endometriosis. Now, what are the differential diagnoses of the endometriosis? Stitch granuloma, neuroma, desmoid tumor, neoplasm, hematoma, and abscess. These can be the differential diagnosis of the endometriosis. Based on the FNAC of the lump, a diagnosis of scar endometriosis was made. The patient went back to the surgeon, and on the basis of the cytological report, the surgeon did the excision, the surgery of the lump. The surgical excision was done, and the excised tissue was sent for the histopathological examination. So on histopathological examination, the I received the tissue sent was creamish white from nodular tissue, which was cut open. The processing of the tissue was done, and the HNE stained sections. Now, here are the attached histopathological images, which are showing the endometrial glands and endometrial stroma, along with areas of hemorrhages and necrosis. A small
One
amount.
second, Shweta. Can you please change the next slide, please? Please say next, Shweta, because it is easy for us to change the slide.
Yeah, ma'am, I was on the histopathology slide. Ma'am, after this, differential diagnosis. Ma'am, yeah. Ma'am, next slide, histopathology slide. Yeah. So, ma'am, the histopathological examination, it confirmed the diagnosis of endometriosis. So, ma'am, this was the case study on the cytology as well as the histopathology confirmed the diagnosis of scar endometriosis. Now I did the follow-up of the patient. I called the patient. The patient came to me and she was telling that now she is relieved of the discomfort and lower abdomen pain. Her overall condition was absolutely good. And now, what are the key learnings from this case, ma'am? The next slide. Yes, ma'am. The next slide. After this, ma'am. Yeah. So the key learnings from this case are the diagnosis of scar endometriosis may be challenging. Cyclical changes in the intensity of pain and size of the endometrial implants during menstruation are usually characteristic of classical endometriosis. Histologically, endometriosis is characterized by the ectopic presence of endometrial-like glands, spindled endometrial stroma, and hemosiderin deposition either within the macrophages or in the stroma. The significance of pathological investigations in such cases is very high as it helps in accurate diagnosis and in ruling out cancers, which further helps in appropriate and timely management. So, ma'am, this case, I was quite happy because very few times it happens that we get the diagnosis confirmed by cytology as well as histopathological examination. So I did the follow-up of the patient, the cytology as well as the histopathology confirmed the diagnosis of endometriosis, and the patient was absolutely fine after the surgery. Thank you.
Thank you so much, Dr. Shweta. It was a pleasure to have you. Anybody would like to ask her questions? Yeah, that was a simple and a sweet case, I think so. It was really nice to have both cytology and histopathological confirmation. Usually, we get the adipose tissue when you do an FNAC and, you just miss the endometrial tissue. But I think it's a bingo for you to get both the tissues in both the FNAC and the smile on the patient's face will really help you do much better. Yeah, it was wonderful. Thank you so much, Shweta. Thank you. I now call upon the next speaker, Dr. Rosa Angelica Barbella Amponte, if I'm right on pronouncing your name, from Spain. She is a surgical pathologist in pathology department of General Hospital of Albacete, Spain, professor in the Faculty of Medicine at Castilla-La Mancha University. Her topic for today is sentinel lymph node in breast carcinoma, which is the best decision. I would love to listen to your case, ma'am. Thank you.
Thank you. I'm sorry. I'm going to start it. Do you see my presentation?
Yes, we can see, Dr. Rosa, your presentation, and your voice is absolutely clear.
Okay. If you don't mind, if you have any question, try to write this because my audio is not quite well. So before that, good morning. Before I start, I would like to thank you for this opportunity to participate in this interesting multidisciplinary event. So I understand the organization and leading so many people is quite difficult, but I think it's very, very interesting. It speaks us about the valuable of the difficulties would be arrived. Today I want to talk to you as some subject that in my view has created continuous doubts about the decision once the sentinel node is positive, which from my perspective, in the case of breast cancer, we should consider evaluating several sentinel nodes and not just one. So, and it's the topic where I'm going to talk today, and I'm going to try to be concise and leave some ideas on how we can handle the outcome and its influence on the axillary dissection. My name is Rosa Barbella. I'm a pathologist and I'm working in the General Hospital of Albacete in Spain. And I'm assistant professor in the Castilla-La Mancha University. And these are my colleagues, especially my surgical surgeons, Ana Sanchez and Esther Sanchez were working side by side with me. in this work. So, studying the sentinel node in breast cancer was a significant step in managing the patient. It has allowed to define the state of the disease and increase the life expectancy of the patient with breast cancer. Recently, we have able to avoid axillary dissection and reduce the complication, but there exist several protocols to avoid lymphadenectomy. And as you see, sentinel node and axillary treatment is very colorful. So what's the best route for axillary treatment in breast cancer patients that improve overall disease-free survival? Let's see some information. So in these slides, I want to show you 4 of the many articles that have been published since 2012 regarding axillary management. As many will know, the project ACOSOF Z11, colloquially called Z11, directed by Armando Giuliano, showed that it's possible to avoid axillary dissection in women with lymph node metastasis. Still, so many authors and research in that the study had weakness. So including the ages of the patient who entered in the study, the biological types they weren't considered, and mastectomy, what about the mastectomy? And the time they had elapsed between surgery and the publication of the results. After 10 years, they review the results and confirm that the survival of this patient remained the same or similar, but avoiding surgical complications as long as complementary treatment existed. So, no longer the radiotherapies, and in this study, Amorós, showed that certain patients with axillary radiation therapy could replace the dissection and thus avoid double axillary treatment. This is an interesting point for many specialists, but they did not agree at all. Among these, my radiotherapist, it doesn't agree with with this kind of treatment for the patient, because if he thinks we have to do all the time dissection in the case that we need. But the rest of the committee of my hospital think we can avoid some surgeries in a specific patient. But what happened? We use in Spain a specific molecular evaluation of the lymph nodes. So the difference between this ACOSOF and our work is the ACOSOF uses a histological evaluation, even while they demonstrate the axillary dissection can be prevented, but in our case, we use this method, OSNA, we call OSNA method, the one-step nucleic acid amplification, where we measure mRNA of CK19CK through RT-PCR. So in our case, we evaluate the entire node, counting the total tumoral load to all nodes evaluated. So we consider, or the commercial house consider macro metastasis each case with 5,000 copies of mRNA CK19, micro metastasis between 250 and almost 5,000, and negative less than 215 copies. So in the totality of the average of the study, we evaluate between 1 to 3 nodes on average. So Giuliano's, we understand that Giuliano only evaluates one node in most cases. So how we can transfer this result of Giuliano with our form or our way to evaluate the lymph nodes? Because the technical difference between two forms are very, very important. No? The difference, I'm sorry. Meanwhile, oncologists and surgical surgeons press for use the new parameters to be applied. But how? What do I do as a pathologist to combine these different ways, adapting the result of Giuliano with our way to diagnosis? I want to show you briefly an overview of the original Sentinel node study was made. They use a node, separate in 4 portions, 2 of them homogenized in a special solvent, and then using in this machine, using RT-PCR as is performed on the CK19. Using a positive and negative control in the test sample. The result we obtain as in exponential fractions, and then they compare this fraction with this fraction evaluated by a histological way or traditional way, and then compare the values with the size of the tumor on the slides. So this method assume that 5,000 copies is the same or it's equal to 2 millimeters of the 2 millimeters size in the slides, in hematoxylinosin slide. So it still exists. What we're going to do with the number of the copies of cytokeratin 19. So in Spain, the Spanish group leading by Vicente Pech and Isabel Rubio from Barcelona constructed this normogram for the evaluation of Sentinel node, searching a new cutoff points. They find that the cutoff point for macro metastasis could be up to 25,000 copies, measured as a total tumoral load in all evaluated nodes. From my point of view, there was still no solution if we want to adapt C11, because they said just one affected lymph node could avoid lymphadenectomy. But our molecular studies tell me that the tumoral load, either one or more nodes could be used. So it's difficult to decide. Here we present a different protocol using by Italians. Using by Italian, in this case, the group of Francesca Combi published the result of the use of the residual disease risk calculator, created by the Italian Society of OSNA user, in which tumor size is combined. Here, they put the tumor size with the number of copy of mRNA CK19, make a calculation, and they obtain a probability to a risk disease progression. They put a cutoff point in 31%. So in this case, they simplify the selection of patients for axillary dissection or not. In 2018, I decided to present my result of my doctoral thesis. In this case, or in this slide, you can see the distribution of the biological profiles. In this study, I include only these women who were evaluated by OSNA method, and here I showed you some results. As you see in this case, luminal are the predominant type of biological types, and either luminal A and luminal B, and then HER2 and triple negative group. There were very low representation. And here we have how this graph, we observe the distribution of the number of nodes evaluated during that period. As you can see, more than 50% of the evaluated sample had more than one sentinel node, and in those cases with the lymphadenectomy performed, more than 70% of the cases had between 1 and 3 affected nodes, even though non-statistical significances was found. In this case, I show you another part of my thesis is about the distribution of the micrometastasis, because I think this topic is still being difficult to decide what to do with this kind of patient, especially because some authors insist that there is an influence, their presence has an influence in the evolution and disease-free survival of patients. As can be seen in this table, micrometastases were found in greater numbers between this group, women with 50 to 59 years old, around more than 50%, and luminal A between 40 and 49 years old, and here too, the same in the same ages. But the difference with micrometastasis, we found most of them in the cases of luminal representation, and few ones in triple negative. If you see, we didn't find micrometastasis in patients with triple negative cancer. At this point, we define more or less what about the breast cancer behavior in our province, and has allowed to us to establish certain criteria to define auxiliary management protocol. In this slide, I show you an update the survival data in women with 2 and 3 affected sentinel nodes, regardless of total tumoral load. As you can see, lower survival is evidence comparing with those who has just only 1 node affected. Another work that we did because we saw specifically luminal B are the most, for us, are the most difficult type of cancer to treat. We decided to study this group. Okay, from the previous result, it was important to note the luminal B tumor usually have 2 most micrometastases in the most affected node. In this study, we studied the behavior 94 cases of women with luminal B carcinomas in 10 years, and we find some interesting. One of them was the tumor, the size of the tumor, because we saw the overall survival in patients with tumor more than 16 millimeters has with survival 94 months. If we compare with some patient with tumor with size less than 15 millimeters with 102 months. In the combination macro and micro metastasis, the overall survival was 68 months. That's why we try to organize a protocol, not as simple as Italians, but I think it's quite good. We decided to combine the recommendation, the 11 studies, since agreed the quality of life of patient could be improved using OSNA as a diagnostic method. In order to design a specific protocol, I decided 2 groups. One of them as a low-risk group, luminal A, and a high-risk group in tumors, luminal B, HER2, and triple negative, both for women who receive conservative mastectomy and post-neoadjuvant surgery. This protocol were discussed in several meetings with the rest of the members in the committee, and annually since 2018, we review the guidelines. At the first, it was difficult to follow this criteria, but for now, the pathologists play a fundamental role to comply this protocol. As you see, we accept patients for no axillary dissection in those cases where clinical and radiological negative axillary evaluation and conservative surgery. We accept until 25,000 copies. If we have to do delay path analysis, 1 micro and macro metastasis, 2 micro on a unique macro, and a special consideration 3 micro metastasis, especially in those cases with lobular carcinoma. The adaptation of Z11 only in cases luminal A or low grade with any total tumoral load until 2 nodes. In these cases, we don't do an axillary dissection. In those cases, we have to do this axillary dissection or lymphadenectomy more than 25,000 copies, or if we find in the path analysis 2 macros or 3 macros, or the third positive node with any tumoral load. If we find a positive node by radiological confirmation, radiologists make a marker with a metallic marker or magnetic seed. We use the same protocol, but all the time searching for the third positive node to complete the axillary dissection. Okay, we decide all the time examining 3 nodes, not only 1, not 2, 3 nodes to complete a real or expand our knowledge about the sentinel node. That's why I said it's impossible to evaluate just one if we want to capture or get more patients to avoid residual tumor in the axillary evaluation. In the case of mastectomy, we only accept negative clinical and radiological negative axillary evaluation. So preoperative phase in women more than 50 years old, tumors between T1 and T2, not adjuvant treatment or partial responding single tumors. We only admit 1 macro metastasis. Since 2018, we use this protocol. There is some preliminary results. We evaluate from 2018 to 2022, 500 patients with sentinel node evaluation with average age, 80 years old. 1.2% were men and 300 women with postmenopausal data. After the surgery, the distribution of the stage, most of them, the stage 1, stage 2A. And the average evaluated nodes was 3.5. The average node from after lymphadenectomy axillary dissection was 24.7 nodes. As you see, there is plus more than 80% of the sentinel nodes were negative. Around 18% of the sentinel nodes were positive. The axillary dissection was made in around this number or this percentage of cases. The interesting thing, we find that more than 50% of these cases had 3 or more nodes affected. So we consider that this protocol covered all these patients and reduce the activity or reduce the opportunity to lead some patients with residual carcinoma in the axillary reviews. The biological profile we find a little compare. If we compare with the preliminary result, we see a slightly increase of triple negative cases, but the rest continue the same. We see breast relapse only in 2 cases. In these cases, with sentinel node positive. In axillary relapse, only in 1 case, but in this case, it wasn't a positive sentinel node. This case was a triple negative women. The rest of the case, we observed distant metastasis. The total case reliefs was 70 cases, 3.4% percentage, and 10 women died in the first 2 years postoperative due to the disease progression. So we think the study of the sentinel lymph node by OSNA is an accurate method to complete the evaluation of tissue. Knowing the behavior of the tumor in the geographical environment allows better definition about the behaviors. We know there's no perfect protocol, but we believe that not all biological profiles should be treated in the same way. So the creation of individual protocol by biological type, behavior, size can improve the subsequent management of the present. And we have present a tool to catalog patients and believe that for now, our results are on the right track, better defining patients who do not deserve axillary dissection. All patients after this treatment receive complementary treatment or hormone blockers or chemotherapy or radiotherapy. So I'm sorry by my English, I was a little bit nervous, but I hope you understand everything or almost everything. And thank you a lot for your attention.
Gracias, Dr. Rosa Angelica. It was a very elaborate presentation and a very, very well said way that I will try to apply your study to my lab if possible. It was a very home-taking point for us. Anybody would like to question her? Yeah, gracious once again, Dr. Rosa, I would love, and congratulations for the Gold Cup by one of your member who's been trained in your country, Spain, Messi. We loved watching your football. I read about that he's been grown up in between 12 years and 17 years with you guys. So thank you for being a wonderful football player and making us enjoy from this part of the world. Yeah, thank you.
Thank you a lot.
It was wonderful having you here. Yeah.
Thank you.
I now call upon Dr. Vamshi Krishnan Birupanani from Silchar Medical College and Hospital, Kachar, Assam from India. He's going to talk about recent advances on parental drug delivery systems in connection with process analytical technology tools. Dr. Vamshi Krishnan, the stage is yours.
Yeah. Good morning, good afternoon, and good evening, all. Hope I am audible to you. Is my screen visible?
Yes, Vamshi Krishnan, your screen is visible.
Yeah, thank you. Yeah, like now, for the next 15 to 30 minutes, I would like to describe on design and development of a pulsatile drug delivery system, which is a paradigm for AM search. It is regarding like now, I would like to introduce like what is the rationale or what is the main concept and what are our main objectives, followed by where we have landed at the end of the study. There is a Norman Lockyer. He's a German astronomer. As per his thing, if there is a particular rhythm or a pattern which was observed, then get hold of it, study it, and record it. And what does it mean to us? It includes everywhere, including the transdisciplinary sciences, including the treatment. As per the current scenario is considered, there are a lot of diseases which follows a certain pattern where the intensity of the disease is quite high at certain time of a day. If you consider a complete day at a certain time of a day, the intensity of the disease is quite high, whereas the other time the intensity is low. Like my aim is to to make the drug available at the time of need, where the optimum levels of when the intensity of the disease is high. And my target is to get the drug available in the systemic circulation at the hour of need. And of all the diseases, as per the WHO 2019 census, around 17.9 millions of people died because of cardiovascular complications, which had made my attention towards something towards cardiovascular diseases. Hence, the best science in pharmaceutical industry is chronotherapeutics, which can be parallelized along with the disease pattern. And there is a case study as per the GT Medical University, Japan. They had evaluated the ambulatory blood pressure monitoring among different patients, different number of thousands of number of patients, and they had concluded that the blood pressure is quite high during the awakening times, plus or minus 2 hours. And from the picture or from the graph, it is very clear that during the awakening times, there is a steep rise in the blood pressure, whereas the blood pressure is quite low during the nocturnal times. It gives me a clear indication that during the night times, there is no need of releasing of high amount of drug, whereas the drug release should be high during the time of awakening times. And a patient can't administer a dosage form just now to have a better patient compliance. He should deliver the drug when he is going to sleep, and during the time of sleep, there is, as per the body circadian pattern, there is no need of release of much drug during the nocturnal times or during the sleep times, which is called as a lag time or a slack time. And after that, the optimum levels of the drug need to be made available in the systemic circulation. That is which is my target. And this term where there is a steep rise in the systolic blood pressure during the awakening times is called as AM surge. And for that, I had used the principles of chronotherapeutics. And as I said, from the case study approach and also patient compliance. And from the third case is if we administer a drug or something, there is a general residence time at each chamber in our GIT, where the residence time in the normal stomach is 1 to 2 hours, followed by the small intestine and the large intestine, which almost takes 5 to 6 hours so that the drug reaches to the colon. And also the drugs here which were selected for the study are diltiazem hydrochloride and propranolol hydrochloride. Basing on their properties, these are extensively sensitive to the gastric juices, and they degrade by themselves. They degrade when they got exposed to the gastric juices. Hence, these particular drugs I have to hinder and should not be exposed to the gastric juices. For that, we have a colon compatible polymer coatings on the drug particulates. So as to mimic or to balance all these 4 conditions like patient compliance, case study from GG College from Japan, and gastrointestinal residence time after administration of the drug, and the drug properties, we had designed a pulsatile drug delivery system, which is a new novel dosage form. And as I said, these are some of the advantages of a chronopharmaceutical drug delivery system. We can mimic or we can synchronize the chronotherapy of diseases, and also we can avoid degradation of the drug in the upper gastrointestinal tract, and also we can program the release of the drug pattern from the dosage form, and also the first pass hepatic first pass metabolism can be prevented. And as far as my drug delivery system is concerned, it permits me to simultaneously administer 2 or more drugs and also improve patient compliance, avoid risk of dose dumping, less intra and inter-subject variability, does not release drug before the desired lag time. Coming to the components of a drug delivery system which was designed, it mainly consists of the drug formulation, where the drug particulates are designed in the form of pellets by booster on the fluidized bed coater technology, and the principle which is used is called as booster principle. And these designed drug particulates are encapsulated in the body of a capsule, and the body, the opening of the body of a capsule is plugged with the help of a hydrogel plug, and then the cap comes into the picture. Here, the main thing is there is a small chemical reaction called as Schiff-based condensation reaction. According to this particular reaction, when an aldehyde group combines with a amino group, it forms a carbinolamines. Here in gelatin, since all the capsules are made up of gelatin, this gelatin consists of amino acids, and the main amino acids are lysine and alanine. These amino acids have amino group in that, and the amino group, when got exposed to aldehyde web, it hardens the shell and doesn't dissolve. That's how these property and this particular reaction is used here, where the shell or the body of a capsule is hardened so that it prevents the drug particles which are encapsulated into that from exposing to the gastric environment. Once the drug particles are not exposed, the degradation can be preserved, and the drug molecules will not get degraded by the gastric juice. This is what like a harmonization of chemistry, and also considering the circadian pattern or the requirement of the patient or the body physiology, we had collaborated and we had combined these two principles to design this particular delivery system. And now here, the main thing is, once the body of a capsule is hardened and a hydrogel plug is plugged and the opening of the body, these hydrogel plug composition is optimized, and the release or the time which the release profile of this hydrogel plug is optimized. The principle is like, now when the capsule is administered into a patient, the cap of the capsule will get dissolved in 5 to 10 minutes, followed by exposure of hydrogel plug to the gastric juices. These hydrogel plug slowly imbibes the gastric juices, and it slowly swells and get detached from the body of a capsule. Once it gets detached, the drug formulations in the form of pellets that are designed will slowly expose it to the gastrointestinal environment, and then it slowly enters into systemic circulation. This is what the main principle is behind this drug delivery system. And also here, each and every parameter was optimized, like the drug formulations and different types of the polymers which are used to design the dosage form were, the compatibility study was tested, as well as the hydrogel plug individually was optimized and tested for the lag time profile. And also as the integrity of the capsule was also tested, and followed by the pharmacokinetic and pharmacodynamic study evaluations. This is my main objective. There is the main drugs which are used are propranolol hydrochloride and diltiazem hydrochloride, which are mainly used to control the blood pressure of a patient. And also, in order to improve patient compliance, as these drugs are used in the treatment of hypertension, which is one of the major causes of heart attack. And these are different types of studies which we carried. Like now, it is a systematic approach where the pre-formulations were evaluated followed by optimizing the final formulation and evaluating each and every characteristics of drug delivery system by SEM analysis, in vitro studies, and in vivo studies. And also the design dosage form was compared with a marketed formulation, and we had observed a significant difference in the release profile, and it is very close to our objective. You can see these are the properties where the half-life, the main important is this propranolol hydrochloride and diltiazem hydrochloride. It has a very short biological half-life. It itself indicates that we need to extend, or we need to sustain the release pattern so that we have a greater coverage of the spectrum, and the blood pressure can be controlled throughout the entire day. And whether our data supports or not, we can see in the upcoming slides. And also the main principle for selecting these two drugs are both are subjected to extensive first pass metabolism, and we need to avoid that, and we had avoided that with our pulsatile drug delivery system. These are the rest of materials, like now polymers, which are used in the study so as to control or to delay the release pattern of drug. And as a start of the study, as per the pre-formulation study, we had evaluated the flow properties of the drug particulates, and also what the solubility profile and the melting points, which are very identical to the things which are in compliance with the official pharmacopoeia. And since you can see the bulk density, taper density, and the compressibility index properties, which are quite low, bulk and taper density are low, and the compressibility index value indicates that the flow properties of the drug particulates is quite low, and we need to definitely improve that. And these are some of the techniques like infrared IR, FTIR spectroscopy, and DSC differential scanning calorimetry. These two studies were done so as to evaluate the compatibility between the drug, between the diltiazem hydrochloride and the rest of polymers that are used in the dosage forms. For that, we had evaluated the important functional groups of the drug, and a drug and a combination of the polymer were used, and these both are compared with the control like the individual drug particulates, which clearly indicates that there is no any significant difference between the functional groups, indicating that each and every ingredient that we have utilized in the study are compatible with the drug. We also used other technique called as differential scanning calorimeter. In that, 1 mg of sample was separated, sealed, and it was compared with an aluminum at a heating rate of 5 degrees centigrade per minute, and a total spectrum was done from 25 degrees to 40 degrees centigrade. And the reference, as said, the reference standard is aluminum. You can see the onset of melting and the melting peak for the individual drug, and a combination of a drug and a polymer or the binder which were used in the study are almost the same, and there is no any much significant difference which depicts that the polymers which are used are compatible with the drug. And after doing these pre-formulation studies, we had evaluated, as I said, as per Skiff condensation reaction, the polymer or the gelatin is exposed to the formaldehyde vapors, and we had evaluated the differences on the physical dimensions of the cap and body. And there is no much significant differences in the physical dimensions of delivery system. And the composition was evaluated with HPMC K4M and lactose at 1:1 ratio, whereas at different levels, with the HP4 composition at a 75 mg of HPMC K4 and a 75 mg of lactose, we had extended the release for 5 hours. It is plugged for 5 hours, and it can prevent the drug particulates get exposed to the gastric environment for 5 hours. And the HP4 is selected for further studies. And at the same time, the plug or the hydrogel plug was evaluated for its weight, thickness, and hardness. The values are given in the table. Followed by, so as to construct or to know the unknown concentration of the drug, we had used the principle called Beer-Lambert's law, and we had constructed a calibration curve at different concentrations of, with specific to 237 nanometers for diltiazem hydrochloride, and a different nanometer or a different lambda value for propanol hydrochloride. The calibration curves were constructed at different buffers so as to mimic the gastric environment, like 0.1 normal HCl in the stomach, 6.8 phosphate buffer, and 7.4 phosphate buffer in the intestinal region with a pH of 6.8 and 7.4. And prior to the start of study with the actual different concentration of polymers and the actual formulations, we also evaluated as a trial or as a preliminary check, we evaluated the hydrogel plug plugged to the body of a capsule, and around 5 hours, we had achieved a lag time of 5 hours with a slight amount of drug leach, and we had control in the actual study. These are the actual formulations. Where is the difference? Like now, the drug pellets which are loaded into the body of a capsule were prepared by seal coating, where the sugar spears are taken, and since these sugar spears are passed through a 30 mesh, and the retains on the 35 mesh were taken, and these sugar pellets are seal coated because they are very brittle in nature, and to avoid the fines, we had seal coated them, followed by loading of the drug onto the seal coated sugar spears or pellets, and then extended release coating with the polymer called as Udragid. And these Udragid also, we had evaluated different grades and at different concentrations, and we finalized the optimized one for the final dosing or the upcoming studies. In case of, you can see very clearly the different concentrations was highlighted in blue color, and different type of polymers like Udragid NM30D, RL30D, and FS30D. The differences in these polymers as well as the concentration of the polymer were carefully evaluated. A similar case with both the drugs, and after the designing of each, like now, drug loading as well as extended release coating, the weight of the samples were evaluated so as to we had kept this as an in-process control so that there is no any overages or any mistakes we had done during the formulation of this dosage form. You can see the values are fairly consistent towards the entire study. Sorry. And also the release profile were evaluated, and from the graph, the percentage of drug release versus time were evaluated, and you can see for the first 5 hours there is no release of any drug, or it indicates that the lag time of 5 hours is maintained, and from there the drug slowly got released. And also with the DF1, you can see the drug, the spectrum of 16 hours is covered, which indicates with increase of the levels of the polymer concentration, the release pattern is slowed down and it is delayed for almost 17 hours. But the T-half is only 3.6 hours, and we are able to achieve that. In a similar case, we had evaluated with the different types of formulations, but now the point of interest is with the DF7, 8, and 9, which were designed with a polymer called as Utilitarian FS30D. And in these cases, the flow properties were evaluated, and you can see the bulk densities, which were very 0.5 in the initial slides. It has risen to 1, which indicates it has a very flow or very nice flow properties, and the flow properties were improved much, and where during the time of scale up or commercialization of this product, it is very easy to scale this up. And you can see the DF7 and the DF8 and DF9 different codings of formulation formulas. With the DF7, we had almost achieved around 17 hours. If you administer during to a patient, when he's going to sleep, if he administered this dosage form for first 5 hours, there will be no, it is called as a lag time, and a total of 17 hours, an optimum quantity or the drug release or the drug is available in the systemic circulation. And the graph clearly depicts percentage of drug release versus time were evaluated. And for the first 5 hours, as said, the lag time is maintained. And with DF7 at 35% concentration of Utilitarian FS30D, we had the release pattern of the drug had extended for about 17 hours. And this DF7, diltiazem hydrochloride, with 35% FS30D, and a similar observation was observed for propranolol hydrochloride also at 35% concentration of Utilitarian FS30D. We also achieved around 17 hours of drug release. That's why, since the cases are similar, I'm skipping the slides and I will go directly to the PF7 and PF7 formulation. This is the one which I'm talking. With a different drug, irrespective of the drug, the delivery system had achieved an optimum levels at for the 17th hour also. And also the mechanism of the drug release as well as the order of drug release were evaluated by depicting amount of drug release versus time and log percentage of drug release versus log time. From the value of regression correlation coefficient values, you can see for DF7, the correlation coefficient value for 0 order as well as the for PEPA mechanism, that is called as mechanism of drug release. There are different types of mechanism of drug release like diffusion, erosion. Since the R value was high for 0 order as well as the PEPA's mechanism, these are the final ones where my drug delivery, the design drug delivery system had followed a 0 order, where the release pattern of the drug is independent of the concentration of the drug that was taken. And the PEPA's mechanism, which clearly indicates the N value is less than 0.5, which indicates that it follows a non-Fickian mechanism, and the drug will be released in the form of erosion model. And in the similar case was observed for the second drug also. As I said, with the increase among the 3 polymers, the pellets coated with Utilitarian FS30D shown extended drug release than the pellets with the NM30D and RL30D. And also coming to the polymer concentrations, the pellets with the 35% weight by weight shown extended release. Hence, like now, the drug particulates or the pellets which are designed with utilized FS30D, and the concentration is at 35% weight by weight. The coding is like DF7 and PF7 were selected for further studies. And since we had loaded pellets into the body of a capsule, the particular pellets which are designed were evaluated for the physical characterization, how like now with the help of scanning electron microscopy, and found that the particulates are discrete, round, non-tacky, and free-flowing, which will help us for scaling up of these particular delivery systems. And also the stability as per ICH Q1C guidelines, like stability testing of new dosage form. We had evaluated stability at room temperature, intermittent, and accelerated conditions for 3 months. And the percentage of drug release were fairly constant, and there is no any significant changes, which clearly indicates the design dosage form is fine. You can see the drug content, or like now we had evaluated the assay at the end of initial first month, second month, and third month, and it is fairly constant. And this is the complete release pattern, how we followed. Like for every 1 hour we had tested, for every half an hour and 1 hour we had tested the delivery system, the drug amount of drug release, and depicted the graphs. The similar behavior was seen with propanol hydrochloride also. As a thing, the results indicate that drug release from pulsing caps were not changed significantly when stored at different conditions, like at 40-75 against 25-60. And we had done a retinography studies, like we need to locate, like once the drug particulates were evaluated and the compatibility studies were done as a whole, once the delivery or the capsule is encapsulated or is administered, where does it locates at the end of 5th hour or 6th hour? And for this, we had depicted for with the help of rabbits, and healthy rabbits were selected for this study. And instead of drug, the barium sulfate, which is an opaquing agent, and to take the pictures and to locate the exact location of the capsule, were evaluated for 1, 4, and 6 hours. And you can see the drug pellets at the end of 6th hour, it's almost reaching towards the column for both drugs. And followed by, we have evaluated the pharmacokinetic and pharmacodynamic studies also in comparison to a marketed formulation with the pulsatile formulation what we have designed. From these, you can see from the data, at the end of 6th hour, in the marketed formulation, the maximum concentration was reached. Whereas in case of pulsatile formulation, the maximum concentration was reached at 12th hour, and is sustained for around 32 hours, and it is further declined, whereas it got decreased a bit quickly at the end of 24 hours data with respect to the pulsatile formulation. And also from the graphs, once the data is depicted, was represented in the form of graphs, in vivo studies, you can see there is, for first 5 hours, there is no any release of the drug in the pulse with the pulsatile formulation, which indicates our lag time is maintained, and the maximum concentration is reached at 12th hour. And also the total area under curve value is almost like 2.5 times folds increase as compared to the marketed formulation, which is a significant difference between the marketed and the in-house developed pulsatile formulations. We got the Cmax values, and also as compared a high Cmax values we got, and also the time it's sustained in the systemic circulation is high as compared to the marketed one. And also the beta blockade efficiency was observed, and it is compared with the sustained formulations for both diltiazem and propranolol hydrochloride. And here an adrenaline challenge was done, and you can see the final results are like in agreement with the pharmacokinetic data. The maximum beta blockade was obtained at 6th hour, as I said. In case of pulsatile formulation, it was observed at 12th hour and extended for a period of 18 hours in both cases. Sorry. From this, the time delayed capsule device for chronotherapeutic delivery of diltiazem and propranolol hydrochloride successfully developed in accordance with chronomodulated therapy of blood pressure, and a lag time criteria of 5 hours was maintained, and a sustained release for around 12 hours was achieved successfully. And these are a few publications with international publications we had on our name, and these are like now a few chronotherapeutic drug delivery systems which are available in the market. And in the coming future, we are liking to we are heading towards scaling up of this particular formulation, and hope we'll have a successful commercial type of product in the coming future. And I thank one and all. Like now, if you have any type of questions, you can ask me.
That was a very crystal clear, Dr. Vamshi Krishnan. Just wanted to know, where are you working from?
Yeah, currently I'm working with Piramal Pharma Solutions at Lexington, Kentucky, USA.
Okay, okay.
Yeah, recently I moved to US around 3 years back.
Oh.
And currently we are designing on antibody drug conjugates and also liposomes for anti-cancer dosage forms.
Wish to see your drug delivered in India. You were really absolutely crystal clear with your delivery. Had a lot of knowledge through your lecture of how was this pulse-style chronological delivery of drugs. Can you use the same technology for anti-diabetic drug delivery? Just a question.
Yeah, as of now, like now, if it has a chronotherapeutic modulated system, and to a particular time we need to release that drug, we can modulate, madam.
Oh, wonderful.
Yeah, like now, like we can collaborate with each other, and if you provide some physiology of that particular diseases, how the disease patterns in particular day, we can modulate by changing the concentration of hydrogel plug, which is there. Yeah, it is very simple technique, and now we can reduce the cost of the drug to a significant level and make readily available to a lot of patients. That's
and the time duration of the drug delivery also, I suppose, because anti-diabetic drugs usually take it up in the early morning and in the night. So your pulsatile chronological delivery system could be used in a different way to the as an anti-diabetic drug, as just a general opinion of myself as a pathologist. A wonderful way of presenting it, Dr. Vamshi Krishnan. I really had a blast listening to your presentation. Thank you so much for joining us. Yeah, it was
sure,
to have
sure.
you.
Yeah, thank you, Dr. Vinila. Thank you.
Thank you
Have
so
a nice
much.
rest of the day. Bye-bye.
Thank you.
Yeah.
So thank you, sir, for your presentation. You really made some great points in your presentation. So now next we have our next speaker, Dr. Kendra Wilson from UK, and she's going to deliver her speech on the review of neglected hepatica fasciola, a treatable risk factor for cholangiocarcinoma in Southern Africa. Over to you, ma'am. The stage is. Kindly unmute yourself and share your screen. Ma'am, you have not unmuted yourself, ma'am. Please unmute yourself. Yes.
Can you hear me?
Yes, yes.
Great.
You're audible.
Can you see my screen?
Yes, ma'am. Yes, ma'am. It's visible.
Right. Good afternoon, everybody. My name is Dr. Wilson. I'm one of the clinical fellows in general surgery. So I understand that this conference has had a lot of pathologists and pharmacology as well. But from a clinician side, I'm going to present a potential curable risk factor for cholangiocarcinoma. I am currently working at Whipps Cross Hospital, which is based in London. However, I'm originally from Southern Africa, and so I've looked at that specifically in that region. So an introduction to cholangiocarcinoma. So it's quite a heterogeneous group of cancers of hepatobiliary origin. And it's got a very dismal prognosis, even in the best resource settings. Up to 95% of patients, when they're diagnosed, will die within 5 years. And globally, this rate is increasing. So we are seeing that the trend is to increase and that there's a male predominance in the epidemiology. The other problems is that it often presents silently, and it is quite an aggressive tumor, and there's a poor response to chemotherapy. And in most of the cases, these are adenocarcinomas. So really in this cancer, if we can find ways of preventing it, there's very poor cure rates. So if we can find risk factors that are treatable, we would be making a significant difference. So if we look at the mortality rates worldwide, I've put worldwide in inverted commas because you can see there are large areas of the globe where we do not have sufficient studies to determine the epidemiology of this cancer. So large portions of Africa, as well as the Middle East, are not included in the recent consensus paper by Benalis et al., which was released in 2020. But what we have seen is that the mortality rates are much higher in certain regions like South Korea, China, Taiwan, and Japan, and I'll go into that later. But what we've seen is that there's in endemic regions, liver fluke infection has a high association with cholangiocarcinoma, and this is through the effects of chronic biliary tract inflammation. In other parts of the world, other risk factors include cholelithiasis, and primary sclerosing cholangitis. But up to 70% of patients do not have an identifiable cause at the time of diagnosis of cholangiocarcinoma, which highlights the need for further studies into the risk factors. So if we were to look at the anatomical classification of this tumor, you can divide it into intrahepatic cholangiocarcinoma, which is anything proximal to the second order bile ducts, perihilar cholangiocarcinoma, which is proximal to the cystic duct insertion, and then within the common bile duct, this is termed distal cholangiocarcinoma. So if we look at the rates, the most common is actually the perihilar cholangiocarcinoma and the distal. So previously, the ICD classification did not distinguish between the perihilar cholangiocarcinomas, and there was also interchangeable terms used like Klatskin tumor or a hilar tumor, or the perihilar and distal were grouped as extrahepatic, and this has implications for the epidemiological data that we have, because each of these subtypes has different risk factors as well as different management plans. So the signaling pathways for cholangiocarcinoma are quite complex, and this is taken from the consensus paper. And basically, the tumor evolution and growth involves quite a lot of complicated intersignaling between extracellular ligands. So cytokines and growth factors and bile acids all interplay with the intracellular signaling, most often through interleukin 6 and the STAT3 pathway. This is beyond the scope of what I'll be talking about today, but it's important to realize that there's multiple pathways and that the tumor microenvironment is very important. And ultimately, it results in proliferation, apoptosis, tumor growth, and migration and invasion. So what about liver flukes and cholangiocarcinoma? So as we've said, there's a high incidence of cholangiocarcinoma in endemic areas, but that is specific to the two variants that have been studied, which is Opsicoccus viverrini and Clonococcus sinensis. And fluke positive tumors show a higher mutational rates in some of the signaling pathways that I've mentioned. So this is a liver section from a patient with known cholangiocarcinoma. So up in the top left of the image, you can see a cholangiocarcinoma, and then within the bile duct, you can see several adult flukes, which are measuring up to 2 to 3 centimeters. So patients infected with ovovirenia are more than 10 times likely to develop cholangiocarcinoma and 7.8 times more likely to develop cholangitis and cholecystitis. And they also have an overall worse prognosis, which is independent of the anatomical location and the clinical staging. Elsewhere in the world, the colodocal cysts and colodoculithiasis have the largest proportion, but you also see it in infections from HBV or HCV, so hepatitis, as well as alcohol and IBD, and some lifestyle factors such as smoking, alcohol, diabetes, etc. So what about fasciola hepatica and cholangiocarcinoma? So what is fasciola hepatica? It's a liver fluke that is found ubiquitously around the globe, and it is also relies on an intermediate host of a water snail, much like its the variants ovovireni, and its definitive hosts are livestock and humans. So this image is taken from a systematic review by Derma et al., and it shows the distribution across Africa and shows that it is present in South Africa. But globally, if you were to look at the papers that have been released by the World Health Organization and other research groups, you'll see that there's a discrepancy with the distribution of fasciola hepatica and what is known in the African review. And it's quite ubiquitous. It's found in almost all countries in the world. So if we were to look at the life cycle, just to understand the pathophysiology a bit better, we see that the hatched Myricidia seek out the snail hosts. They develop in the snail tissue and mature until they basically hatch and insist on vegetation. So commonly, the vegetation associated in the literature is watercress, as this is a semi-aquatic plant. But in reality, they can attach to most plants that are in marshy areas. So I've included there the sugarcane, which is quite common in the Southern African region that I'm from. These metacarya then are ingested by definitive hosts, which are typically livestock, but if they are unwashed or undercooked, they can also be ingested by humans. And from this point, the flukes insist and penetrate the duodenum, they migrate through the liver parenchyma, and then they mature in the adult form in the biliary tract. And then the adults of these liver flukes then release the unembryonated eggs in the feces, and the life cycle continues. So fasciola hepatica has quite a vague symptom complex, so it's difficult to pick up clinically, and unless you as the treating doctor are suspecting this diagnosis, it's unlikely to come across in the differentials. The vague symptoms might include malaise, transient fever, or abdominal pain, but remembering that these liver flukes can live in the bile ducts for up to 13 years. So chronic cases may present more with weight loss or biliary colic type symptoms, or eventually jaundice from the biliary obstruction. However, more than half of patients are completely asymptomatic, and therefore they are not suspected. Another issue with the diagnosis of hepatica fasciola is that it relies on stool sampling methods, largely in South Africa, which are unreliable, as these only detect the adult fluke sheddings of the eggs. And considering natural physiology, bile juice secretion is irregular. It's not always likely to pick it up at the time of the stool sampling. So often you would need repeated stool sampling. And if it's an early infection, you might not pick it up while the flukes are still maturing. Another interesting fact is that the inflammatory mass, which is produced from these liver flukes, can mimic cholangiocarcinoma itself. So often patients will present with a mass, with weight loss, with anorexia, etc., which might prompt the physician to think of cholangiocarcinoma itself. So basic blood tests, you might see deranged LFTs, Utilitarian, through antibody testing. So this is actually the gold standard. You can either use copper antigens or blood antigens for testing, and it's a lot more sensitive than the stool sampling methods. In some settings, an ultrasound might be useful. However, it's often non-specific, in which case you would only see hepatomegaly. But the typical lesions are parenchymal lesions with a halo or periportal tracking, as well as ductectasia. In this image, you can see there is a dead fluke in one of the bile ducts, and that's obviously once there's been chronic infection and the flukes have grown to a considerable size. On CT, you might see subcapsular lesions or tortuous tracts from the migration of the parasites. MRI would show a peripheral contrast enhancement and a high T2 signal. And you can use the apparent diffusion coefficient as a complementary method to differentiate between other causes of focal lesions in the liver. But ERCP is both diagnostic and therapeutic. So the image I've included here is at ERCP, a mature liver fluke is being extracted through a balloon trawl. So not only will that assist with diagnosis, but it will also be therapeutic if you can remove all of the flukes. So the purpose of our review was a scoping review in order to identify any gaps in the literature in order to direct further clinical studies. So we did an extensive evidence search of 5 different platforms, and using the term fasciola hepatica, liver flukes, cholangiocarcinoma, bile duct carcinoma, and South Africa. And basically, we only identified 310 once duplicates were removed. We screened these and eventually have included 52 in the final review paper. And the gaps that we identified is that even though fasciola hepatica is shown to cause tissue proliferation and evasion of the immune system, there have been no human studies to explore this association. As I've mentioned, the lifespan is up to 13 years, and with this evidence of chronic inflammation, it provides a plausible mechanism for the development of cholangiocarcinoma. The other finding was that most of the endemic areas for fasciola hepatica are located in resource-poor settings, so access to healthcare might be limited, and the chronic consequences are therefore underreported and unknown. A systematic review by Machikaro et al. From 2016 found that there were only 5 studies exploring the association between this liver fluke and cancer. So what are the findings that we found? So there's transforming growth factor and interleukin-4 that are upregulated as a consequence of fasciolysis. But even though this is a known potent proliferation factor, it can also inhibit the immune system activation. And both of these are recognized along the cancer pathway in our hallmarks of this. As we've mentioned before, it's quite similar to other gastrointestinal malignancies like gastric or colon CA, where it's a adenoma carcinoma sequence. So the chronic inflammation can result in pre-malignant lesions as well, like biliary intraepithelial neoplasia. One study showed that fasciola actually induced cell death of mammalian cells in vitro, and they implied that this could signify anti-cancer properties. However, with these conflicting findings, we definitely need more studies to explore this association. And this is another image from Bernales et al. And basically just showing how the tissue microenvironment and the cancer-associated fibroblasts play a pivotal role in crosstalk between the cancer cells and the surrounding immune response. So here we can see the role of transforming growth factor as well as other interleukins, as well as PDGF, and various other cytokines. However, what we found was that there's been no epidemiological studies on human fasciolysis in South Africa, and there's no database on cholangiocarcinoma. Some of the limitations and difficulties with cholangiocarcinoma, especially in settings where there's not a lot of resources, is that it's quite a difficult tumor to get a histological diagnosis from. So for example, even in countries with the highest rates of cholangiocarcinoma like Thailand, they have the lowest rates of histologically confirmed cases. They're diagnosed on imaging or clinically, but then to actually get the biopsies is very challenging. But what we do know about fasciola hepatica in South Africa is that well, apart from it being a neglected tropical disease by the World Health Organization, it's quite ubiquitous in cattle. So a study from this year, which was done by veterinary sciences, found that the rates in local cattle are as high as 39% in some of the KwaZulu-Natal abattoirs, which is the province that I'm originally from. There was an earlier study by Ndlovu et al., which showed that there were about 16.3% of cattle which were releasing these fasciola eggs. And if you understand the socioeconomic context of Southern Africa, and specifically in the rural areas, there's a lot of subsistence farming that coexists with these infected livestock, which can result in two things. Number one, contaminated water sources, so especially in marshy areas where there is the intermediate hosts. As we know, the water snails are actually found to be present in 9 of South Africa's provinces. And there's also undercooked and unwashed vegetables, which might be manured by the at-risk cattle as part of the subsistence farming. So these factors make it highly likely that there is a lot of human infection going on, even though we have no epidemiological studies on this. So the fasciolysis map from the World Health Organization did not include South Africa in the distribution of this parasite, yet the systematic review from last year did confirm the presence of several human cases in the literature, which highlights the discrepancy and the limited knowledge at a national and international level. Our main questions from this review is, what is the prevalence of fasciola hepatica in South Africa? Does fasciolysis in cattle have an association with human infection? And if fasciolysis is present, does it predispose to cholangiocarcinoma? So in the paper that I referenced with Mpasana et al., basically we found that there were these 3 regions which had quite high rates of fasciolysis. And then a recent review looked at the geospatial analysis between infected cattle and fluke positive households, and there was a strong correlation between the distance from infected livestock to positive households, as you can see that I've highlighted here. So these 2 papers were both released earlier this year, and for us, it implies that there's a great need for more research in this association, because if the cattle prevalence is so high and there's an association with human infection, it's likely that in our population, this is something that needs to be explored. What we do have from the literature are quite old studies based both done in 2013. Hasana et al. Showed that from stool sampling in children, they were just looking at the general prevalence of multiple parasites, and they found that 1 out of the 162 children did actually have fasciola, which is high considering how rare this parasite is supposed to be in our context. Furthermore, the 2 case studies that I found from Groote Schuur and Cape Town actually showed that even though multiple samples were sent from the patients for stool testing, it was only after samples were sent to London that the immune fluorescent antibody titers detected the fasciolysis. So both of these patients had late and complex presentations and possibly wouldn't have had the diagnosis if they weren't at a quaternary level of investigation and care. Another important point is that the second patient had never traveled outside of South Africa, confirming an endemic focus. What about other risk factors for this cancer in Southern Africa? Well, there's other infectious risk factors like hepatitis B and hepatitis C, which has a high prevalence in South Africa and is a significant association with TP53 upregulation. HIV itself is also associated with a cholangiopathy, sorry about that, and it also predisposes to other infections with biliary tropism. So I found a case of a 17-year-old with cholangiocarcinoma, which was very unusual considering this cancer is normally found in the 5th and 6th decades. H. pylori is also shown to have an obligate mutualism with ovovirene, as it intensifies the degree of inflammation and proliferation. So it's also a risk factor that needs to be looked into with further epidemiological studies. The non-infectious risk factors are, as mentioned, as in other parts of the world. And the reason that this is so important is that the treatment is a single dose of triclopyrdazole. So if you were to look at all the other risk factors, hepatitis B, especially in the chronic setting, is very difficult to treat and cure, especially in the context of concurrent HIV. HIV is a very complex virus to manage, and it's plaguing our population. And the other risk factors are likewise very difficult lifestyle modifications. But if fasciola hepatica is treatable with one single dose, it could have a massive implication for the risk factors and reducing the risk of a cholangiocarcinoma in our population. As I've mentioned, ERCP is also beneficial as a sphincterotomy, and removal of the adult flukes is treatment as well. So in summary, the further research that is required for Africa and South Africa's advocacy for national databases for cholangiocarcinoma and epidemiological studies on human fasciolysis. So this would require some international partnership, allowing for serological testing rather than the coprological methods that are mostly being used. And globally, there needs to be a move towards vaccine development for fasciola hepatica, as well as more human studies exploring the associations with fasciolysis and cholangiocarcinoma. Thank you. I hope that that was clear. Please let me know if there's any questions.
Thank you, Dr. Wilson, for such a great presentation. And you have really deeply impressed the importance of this topic. So do we have any questions from the audience? Any questions? No, ma'am. Okay, then thank you, Dr. Wilson.
No problem, no problem. Thank you.
So now we will go for a short 20 minutes coffee break, and then shortly we will resume this session. Thank you. I welcome back all of you. I hope everyone is back from the coffee session. Let us resume this session. So our next speaker will be Dr. Sadaf Memon from Canada. She will be delivering her speech on the implementation of digital pathology in a large community hospital in Canada, Mackenzie Health, and her personal journey and experience. Dr. Memon, welcome, Dr. Memon. I pass the stage on to you.
Thank you, Dr. Sarkar. Thank you, everyone, for inviting me. So let me share my screen. All right. Okay. Good evening, everyone. Thank you so much for having me over here. My name is Dr. Sadaf Memon. I'm the staff pathologist at Mackenzie Health. I'm also the lead physician in hematopathology and transfusion medicine at Mackenzie Health Organization. I also serve as a chair of General Pathology section at Canadian Association of Pathology. I'm also the clinical assistant professor of the Department of Pathology and Molecular Medicine at McMaster University. This presentation covers protocols used at Mackenzie Health, which may or may not be generalizable to other institutions. Digital pathology implementation is institution specific. There is no one-size-fits-for-all approach. So who we are, so Mackenzie Health Ontario, Canada is basically a 2-site community hospital, approximately 682 beds. Eventually we'll be expanding to 900 beds. We serve over 0.5 million people in Ontario. Mackenzie Health Richmond Hill site. There are 2 sites, Mackenzie Health Richmond Hill site, which was built in 1963, and Cortellucci One Hospital, which was built in February 2021. So the green arrow basically shows where we are. We are in the Greater Toronto area, the Richmond Hill site, and the One Hospital site. So the top picture, the image shows the Mackenzie Health Richmond Hill site, and the bottom picture is our newer hospital, which is the Cortellucci One Hospital site. So we have 8 pathologists, 8 staff. We see more than 22,000 surgical cases, and they were accessioned this year. And more so in cytology, and over up to 300 bone marrows as well. So Mackenzie Health and Cortellucci One Hospital are Canada's first smart hospital that has fully replaced microscopic glass slides interpretation to digital pathology whole slide imaging platform. For our digital pathology whole slide implementation, we strictly followed the College of American Pathology clinical practice guideline recommendation and good practice statements. We have successfully validated our whole slide imaging digital platform. As we all know that whole slide imaging for histologic assessment of pathology specimen has recently got great attention in the pathology world. Prior and recent studies have shown that digital images and microscopic glass slides can be interpreted with comparable diagnostic accuracy. Our aim at Mackenzie Health was to make sure to make accurate diagnosis at least at the same level as microscopy. So having said that, we have then identified and then rectified interfering artifacts, technological errors that could have compromised patient safety. So like in any organization, the initial challenges anyone who wanted to implement digital pathology would face in terms of pathologists, the most common fear that the pathologist would have, it's not my microscope, it's unproven, it will slow me down, it will threaten my job. What's the point? What's in it for me? Why change? The other huge challenge in the debate would be from the institution perspective, which would be cost, which is the biggest challenge, and disruption to traditional workflow. And the other ones are no guidelines or best practices recommendation. There are lack of regulatory approval, medical legal concerns. So if you look for the case for digital pathology, usually whenever you look for the case, you look at it like a business case, return on investment, cost to implement versus cost saving plus revenue, and return on investment is usually 3 to 5 years. If this is the case, it fails in most institutions. There is no business case. At Mackenzie, we did strategic investment. We thought that way digital pathology is the new paradigm required for contemporary practice going forward, essential platform for incorporating artificial intelligence into routine practice. So here is our journey. So we began in 2018 with the startup discussions, the site visit, the commercial discussions, internal stakeholder discussion. In 2019, we started our validation process. We finished our validation and installation in 2020, and the pathologist offices were set up in 2020, and we went live. So we leveraged the Philips digital pathology system, and which is our existing system, and we have contract with them. There was no RFP required. As you can see on the left side of the image, basically we're showing the 2 scanners. We are getting the 3rd one as well that has effectively and very smoothly incorporated into EPIC, which is our laboratory information system, or LIS. And then this red circle is basically showing that the images, whatever, are scanned, and then this is the way how we see our images, and that can be zoomed in, zoomed out with quite effectively. So digital workflow, we basically scan more than 7,000 slides per month, and it is rapidly increasing. Scanning is performed by our dedicated histotechnologists from 7 a.m. to 8 p.m. with one overnight run. And how we did that, we basically added 2 full-time FTE to support the digital pathology. The manual image QC do occur before the cases are assigned to pathologists. So this is my favorite part. So we have placed the quality assurance and the quality control procedures in place. That means that the slides will be QC'd by the dedicated histotechnologist to make sure that the slides are complete. There are no missing tissues. There's no blurry images. So they will do the QC step before it is ready to review in pathologist list. So initially all images were reviewed, and current emphasis is basically more on the biopsies. Digital archive and retention policy for images used for diagnostic purposes. Currently, there are no industry standards. Emerging standards as per College of American Pathologists requirement for glass slides retain for 10 years. In Canada, the glass slide retention is 20 years. For cytology is 5 years. So we are following for digital pathology images up to 10 years with the backup as well. So how do we store advantage? We are using on-premises over cloud. It's cheaper than the cloud, less than half the cost, especially as the archives grow. It has faster retrieval with fewer layers, firewalls, network, and switches. Mackenzie Health already uses monitors all mission-critical IT system. So predictable cost, no downtime when capacity is added. So this is very important, digital pathology and histology. Remember that poor histology is poor image quality. So whole slide imaging diagnostic purpose, there are properties of the optimal H&E slide. Whenever you're thinking to implement digital pathology, it's very, very important that your histology is perfect. So even section thickness, approximately less than 5 micrometer is optimal. Balanced H&E staining, tissue placed on the center of the slides, away from the cover slip or the label. There should be no tissue fold, no scoring or chatter from a chipped microtome blade, no more than 3 serial sections. So we are doing 3 serial sections in one slide. We're not putting more than that because it becomes too overcrowded, and then you will have difficulty in interpretation during the WSI whole slide imaging. No more than 3 serial section level per slide. There should be no air bubbles under the cover slip, no dirt, no or paraffin or mounting media on the top of the cover slip. So in addition to that, we also placed an additional step was to improve the histology and the quality image. So we basically purchased this software, it's whole slide image quality improvement program, HQWSI, and this is the digital pathology certificate program as well. It comprises of 7 modules. The link is provided there. So all our histotechnologists and all our staff, including some of the pathologists, they did these modules, and then they underwent and did the test at the end of this to achieve the certificate, and this fairly improved the outcome. So what are the methods or the steps required to implement digital pathology? First of all, pathologist training, laboratory staff training, IT support, setting home workstation, and we will discuss that further, validation process, and ongoing management process. So our pathologists were trained intensively using the whole slide imaging digital pathology platform by dedicated trainers. User guide and standard operating procedures were followed. Dedicated for lab staff training, dedicated lab staffs were assigned duties to scan the glass slides. Lab staff were thoroughly trained on digital WSI platform. SOPs were created and followed. Proper quality assurance and quality control measures were in place. IT support, that is the key. IT support was made available for extended hours to assure that the system is in place, it's working effectively, and pathologist turnaround time is not compromised. And any IT-related issues which occurred, it was effectively dealt with by our skilled and dedicated IT team. Setting of home workstation. So we as pathologists, we were given an option to work from home in our home workstation and home offices, which was validated during this process. and home workstation were set up by our IT department effectively as well. So post-validation to full adoption. So July 2020, we scanned all the surgical slides and delivered glass slides to pathologists for all cases. In August 2020, the pathologists read glass and digital, both for routine cases at their own paces. In December 2020, we started our home workstation as well in advance of our move to CVH. So CVH is our Cortellucci 1 hospital site. Initially, all the pathologist offices were at Mackenzie Health Richmond Hill site. In December 2020, there was a move that all the pathologist offices were in the newer building in the Cortellucci 1 hospital site, which is the second site which was opened. So full adoption journey occurred on May 10th, 2021, and we did celebrate our first anniversary where our last pathologist asked to stop receiving glass slides up front. But we were always assured that glass slides are available whenever we wanted. So this is my favorite image again. In January 2021, this is the cubby where all our pathologists, and we have added the 8 pathologists now as well. So these are the 7 pathologists that started, and we were given glass slides at that time. All our images were scanned on using WSI platform. On May 10th, when the last pathologist said, no more glass slides, I'm ready. So the glass slides were no longer delivered, and here we are. Now our cubbies are empty, even our hospitals are empty. All we do is whole slide imaging, except for the cytology and the bone marrow aspirate, where I am the key figure and I do that in our department. So this is our office workstation at the hospital. As you could see that we have 3 monitors. The middle one is the barcode monitor. It's a bigger monitor. We still have our microscope. So on one of the monitors, there is we do our EPIC LIS system. The second, the middle one, we use it for our image analysis, and the left one you can use for your own browsing, your personal emails, or your personal references if you wanted to check. So the microscope is always there, and I will tell you that when would the need arise and when do we look at it. So this is our home office workstation. Or the remote workstation. The hospital, this was issued by our hospital and supported by our hospital. This is identical to the office station that we have in the hospital, except for this middle monitor, which was the bigger Barca monitor. But to be honest, just the standard HP monitors were more than sufficient for us, and I am effectively using it since December 2020. It's now 2 years down the road. There is no issue at all. The other important thing is there is no microscope at our home workstation. So basically all we have to rely and do it was on digital. To be honest, I would say the pathologist having that option of working from home was validated during this processes. And I basically call it a huge driver mutation, because when you're in the office and you have your microscope with you, then you will, as a pathologist, before even adopting the newer technology, you will always go back to your old conventional way. So in our home workstation, we have no access to microscopes. So we know that we have a list. We know that we will be looking at the case. So how I basically looked at my cases at my home workstation. I incorporated it into EPIC or LIS system. I reported them. I did not final verify until I went into my office and looked at the case under the glass. And I did that for about 20 cases, different types, small GI biopsies, smaller malignant biopsies, breast, lung, kidney, urinary bladders and all. And then I went for my larger specimens as well. This is the way how I develop my comfort and develop trust and confidence in the technology. When I saw that there was no difference, so we basically at Mackenzie Health Organization, we did that validation study as well, in which all the pathologists were required to look at 20 cases at home and then come back at work and look at the same cases at the office workstation where we have microscope, and just to see and compare, is there any difference? Are we losing anything, or are we missing anything? Is there a challenge there? But to be honest, there were none. We became more and more comfortable. In December 2020, when we were in midst of pandemic, this home workstation helped us as well, because for the sick time and self-isolation, which was more common around that time during the COVID-19 pandemic, we are still there, but this home workstation did not lag behind our work, and our turnaround time did not change. So digital pathology landscape in 2022, a major rethink has occurred over the last 1 to 2 years of pandemic. Labs all around the world have successfully gone digital in different countries. Enabling functions of digital platform is there is benefit beyond laboratory. So consultation network, right case to the right pathologist at the right time. And the other important thing is artificial augmented intelligent tools. If you have the digital pathology platform, you can incorporate that in your organization quite effectively. So in addition to the digital pathology, our frozen sections are done at our Mackenzie Health Richmond Hill site. So all our pathologists, they work at the Cortulucci Ward site, which is about 20 minutes drive from this hospital, or older, the first hospital that we had. So all our frozen sections are done there. For our frozen sections, we use the video microscope telepathology Sakura Vision Tech M6 system. So there is the pathologist assistant, the PA, and the medical laboratory technologist on site daily. So basically, we would do the gross review of the specimen through iPad or MS Teams, and then they will cut the sections for us and they will upload onto the Sakura system. And since January 25, and it's been now almost about a year now, we have been effectively doing a frozen section, and none of us have driven to the other site to look at our frozen section on glass. So touch wood, this has been working very effectively. But before implementing even that, we had to make sure that we had made aware of our surgeons that this is the change that we are doing. They also toured our department, the site, to just see that the system that we are using, if for God forbid, if the system fails, we know that we're just 20 minutes away. We will just quickly drive and go and look at it on glass if need be. So for the pathologist, the outcome was the comfort level. After the implementation, the pathologists are now comfortably signing out cases and working comfortably in their home offices as well as in the hospital. So we are expected to be in the hospital when we are on call. The day of our call, we are given peripheral blood smears, we are given cytology specimens, and we look at it. And we are doing a Sakura system, which is on site as well, and as well as on our computer system as well. The digital pathology adoption rate increased from 10% December 2020, where I was the first pathologist who started using digital pathology in my organization, to approximately 100% on May 10, 2021, when all our pathologists has completely transformed and started using digital pathology for complete sign-outs. Turnaround time. This is really important because that will be the question you'll be asking. Would it increase our turnaround time? So I did the study during my Master's of Healthcare Management Studies from Schulich School of Business. At that time, I conducted the study, and then in that study, the yield was the average turnaround time was 7 days, even before and after implementation of digital sites. So basically, for microscopic interpretation versus the digital whole slide interpretation, the study that we did by looking at our EMR by our management team, it showed similar results. So it did not increase the turnaround time. And to be honest, I would say that digital pathology is a bit faster for me. And most, they think that the interpretative time is approximately roughly it's the same. And that was proven by our turnaround time study that I did. And the fear of the pathologist about the increase in the turnaround time was relieved when the data was shared within our group during our staff meeting. In addition, this also provided an informal expert consult for the pathologists. We obtained consultation from our experts in United States and all around Canada. We found this platform quite effective because we are not actually sending them glass slides or sending them the paraffin block, but we are actually sharing images with them. We managed to export our images to Path Presenter software and transmitted this whole slide imaging to consultants via email or other ends within minutes, as this was an informal consult, so the patient's identifiers were remote. So the outcome, if I would divide it into pre-analytic, analytic, and post-analytic. So pre-analytic, lab and admin staff, they all think that it's faster, cheaper, and easier. Analytic, the interpretative part where the pathologists come into play, it works for us. It works for me. The initial comments were, when before the start of the digital pathology, it will slow me down. The opinions change. It works for me. Disrupts my schedule. Opinions change. Work for me. What's in it for me? Those cohort as well, their opinions change, that it did work for me. For post-analytic, if we see, we always wanted to scale it, clinical staff and patient. So the follow-up appointments for our patients were kept as schedule. So when we started using digital pathology, our patients' appointments were not moved. It remained the same because our turnaround time did not change. So as of now, 8 of 8 pathologists are using digital pathology. No glass slide is delivered, and implementation of the home workstation was a huge driver mutation. Let's switch gears, as we all love purple and pink. So I'm just going to share a few images. So this is the scanning power of the colonic polyp. I'm not here to teach tubular adenomas, but just to show everyone how the system looked like, because these are just the screenshot and the static images. But digital pathology works exactly like your microscope. Instead of using the microscope, you're using the computer mouse, you're using the joystick or anything, whatever you're comfortable with. You can just zoom in, zoom out. There's no pixelating. All you need is a very good internet support and a very good IT support system. So this is the scanning power of a colonic polyp. As you would see that at this low power that you're seeing, there's a lot of proliferation and semi-denominators change. And when you go on a higher power, this is just 20x, you can easily make the diagnosis of a tubular adenoma as you would do on your microscope. Another example of the colonic polyp, you will see down there is some adenomatous change and some proliferation of these glands again. And then if you go on slightly higher power, and you will be able to make the diagnosis of tubular adenoma with no difficulty. So you can make this diagnosis within 2 minutes as you would make it in your microscope. So this will not slow you down. This is another example. This is gastrointestinal stromal tumor. So as you can see, a well-circumscribed nodule with sort of spindle cell proliferation with some hemorrhage in the background as well. This is the scanning power. This is the higher power. As you could see, those spindle cells and these red circled areas are actually highlighting mitosis. The beauty of this digital pathology is you can annotate your slide. You can actually exactly find the hotspot, and you can make the area, like for the GIST, we need, according to the College of American Pathology cancer tumor protocols, you would need the 5 millimeter area where you have to count the number of the mitosis and write the risk level accordingly and grade it for your GIST. So you can actually annotate it, you can mark that area and do your mitosis. We as pathologists, we get interrupted many times by our phone calls, by consults, by someone knocking at your door, be it the lab or another pathologist colleague. So we have to look outside the microscope, and then we have to go back again. We have to find that area again. For the digital pathology, the beauty of it is you can annotate your slide, and if somebody is there, you will be uninterrupted because your images, your annotations are still there, and you can go back without any problem. So I find it quite easily. So the other part of it is, as we all know, that we use immunohistochemistry to support our diagnosis. For GIST, you can actually see that how beautifully I can align all my immunohistochemical markers and look at it effectively. So this just CD117, DOG1, CD34 positive, co-expression, negative for Desmond, SMA, and S100. So in one glance, you can put you can put as many immunohistochemical slides together, and with just one click of the mouse. And you'll be able to see that co-expression easily. So that makes my work quite easier, and it saves a lot of time again. Malignant melanoma, this is another example. I just wanted to show, as we all struggle, we all do the measurements, the margin status. So I have annotated this slide for today's presentation as well. As you're seeing, that red line is basically showing the breathless thickness, the clots level, and then you're seeing this, the green line at the bottom right is basically showing the margin status. This is the scanning power. And on the higher power, I'm actually looking at the 1 millimeter square area, the bigger circle, and the smaller circles are basically the mitosis that I have counted for these. So you can see this melanin pigment, and these are the mitotic figures on the higher power. So you can actually count your mitosis quite effectively. This tool we use for our QA, first-time diagnosis in the community hospital, as most of the organizations do, is always reviewed by the second pathologist as well. So we do our QAs and by sending the cases. So if my colleague is working from home or from his office, all I have to do is just pick up the phone, and we can see the case simultaneously. If he's using one color, if he's using the green color, I'm using the red color, and then we are basically saying, can you look at this point, this area, what do you think about it? And we basically do our consults together in real time as well. So this is another added advantage. This is the margin status. You can actually see this margin as we no longer, I mean, if it's less than 1 millimeter, we say less than 1 millimeter. But over here, this green line is basically showing that this is 0.643 millimeter. You can give that much accuracy on digital pathology. These are my real cases and my real workshop cases that I did. Lymph node metastasis, this is the example of the metastatic breast adenocarcinoma to the lymph node. So over here, even on H&E, it's easy to find. It's not, once you develop the habit of looking at it, so with no difficulty, you can notice this micromet. I don't even require immunohistochemistry to support this. This is an example of an invasive colorectal adenocarcinoma. So as you can see, there is invasion, and over here, this busy blue circle, blue area with multiple annotation, and then we go on a higher power to show what it is. So basically, I'm looking for the tumor budding. So this is the 0.785 millimeter square area, and I have counted the number of the tumor buds. So this is on the right side of the table, basically. This is from the CAP synoptic protocol. The tumor budding is basically, you count one hotspot field, total number of areas should be 0.785 millimeters square, and based on your microscope. So this is basically 0.785 millimeter square area. So when you count, if it's high, it's 10 or more. So of course I've counted more than 10. So this is more than 10. This is just for today's interest. I'm showing over here the tumor budding. This is the pancytokeratin A1A3 immunohistochemical stain. We all know that tumor budding should always be counted on H&E in cases of obscuring factors like inflammation, immunohistochemistry. For cytokeratin, keratin stain can be obtained for advancing edge of the tumor, but the scoring should always be done on H&E. Just for today's interest, I'm just showing you all that how beautiful the images they look like on digital pathology. So if I go back to my case right now, the one that I have diagnosed, I can actually go back and look at the slides, and they have I have did the annotation. I can remove the annotations if I like, but these are the annotations that I already made on my slides as well. Shifting gears, let's go to the benign part. This is the example of the gastric biopsy. This is the gastric antral biopsy showing chronic active gastritis. Over here on the left side of the image is at H&E. You see the fuzzy border, and here you're seeing some sort of organisms. On the right side is the Wharton-Starry special stain. This is the 40X. You can see the beautiful H. pylori organisms over there. Let's move to hematopathology. This is the lymph node biopsy, the lower power, the scanning power of a lymph node suspicious for a lymphoma. And this is the higher power. You can see these are highly pleomorphic atypical cells with permanent apoptosis and necrosis over here and mitosis. So this is diffuse large B-cell lymphoma. Of course, this was supported by immunohistochemical stain, and it proved to be a DLBCL. And I have sent for reflex testing to exclude the CMEC for DLBCL. So this is a bone marrow biopsy. Of course, it's not advocate, but for today's presentation, I'm just showing you that we have also validated the bone marrow biopsies. The aspirates are not, which I will talk shortly. So I'm the one in the department who look at the bone marrows, and I have validated approximately 40 biopsies on H&E and also on glass. And I have seen the comparison, and approximately all of the cases, they look exactly the same. So I look at my bone marrow biopsies through scanned whole slide imaging. So this is the higher power of that biopsy. As you can see, this is hypercellular marrow infiltrated by sheets of these plasma cells, and these pink large cells are the megakaryocytes. And on the left-hand, on the extreme left top corner, you're seeing the erythroid precursors and granulocytes as well. So again, I scanned all the immunohistochemical markers. You're seeing the top one, CD117 positive, CD138 positive, kappa restricted, and cyclin D1. So this is multiple myeloma. It's negative for CD20, CD3. When do you defer to glass? That's the important question. So why and when? Image quality. Usually in fractured bones, and if there is a fractured margin or something, sometimes there was a 3D appearance. There are three different planes, and you cannot put your condenser up and down to actually focus. At that time, we are required to pull our glass slides. So what I would do in our Epic LIS system, I would just put one comment, pull glass slides. The glass slides will be available in my cubby, and I can go and look in my department if I'm working on site. And if I'm working off-site, then I would just go the next day, or if I wanted to go the same day, I can actually go and look at the glass slide. Rare diagnosis, you just want to make sure you're not missing anything. So far, we have not. Limitations of WSI or whole slide imaging is Thiel-Nielsen stain, AFP stain. If you see a lot of microbacterial organisms, TB organism, they're easy to find, but of course you want to exclude that. You want to make sure that you're not missing MTB or Mycobacterium tuberculosis organism at all. At that time, I would pull out my glass slides to just make sure that I did not miss any organism. Fractured bone, as I mentioned, Congo-red stain for amyloid, because there is no polarizer on digital pathology. Crystals, if you wanted to polarize, of course, you have to pull out your glass slides. So these are the circumstances where you would like to pull your glass slides. How often? Depends on the pathologist. Some of the pathologists, if they are, I would say, some of the non-experienced pathologists who were not very comfortable with the technology, they would pull out, and that was the case in the initial months when we tried to implement the digital pathology. So approximately less than 1% to 15% where one or more glass slides are reviewed prior to sign out. All of pathologists work from home, some or most of the days. This would have not been possible if it would have happened to deferral to glass, and if it would have been a big issue. So this is not. Work in progress that right now we are doing is it is an essential platform for incorporating artificial intelligence into routine practice. So we are testing and trialing Page tool for prostate, for Gleason scoring, screening of the biopsies for prostatic adenocarcinoma. We are also in the process of validating in our department the Page tool for metastatic breast carcinoma and the lymph nodes for isolated tumor cells for micromet, and also for the grading, for Nottingham grading. In addition, we are also in the process of trialing and validating VisuPharm for Ki-67 estimation and mitotic count, which will be really, really helpful in neuroendocrine tumors and also for breast biopsies, as it was therapy driven. And our future goal is to basically validate digital pathology for wet hematology cases, for example, for peripheral blood smears and for bone marrow aspirates. For bone marrow aspirates, we have looked at several platforms, and we are conducting meetings with them as well, just to see which one would fit our need. So I'm actively the hematology lead, and I'm taking that for a department, and we are currently testing and trialing many of the softwares just to see which would suit our need, which is the accuracy and the comparability is similar to glass slide. For the peripheral blood system, we're using CellaVision at the moment. So I'm sure many of the laboratories are using CellaVision, which is the digital pathology system for the peripheral blood smears. But for the bone marrow, it has no success. So we are still in the process of validating this. With that, I would like to thank our senior leadership, Mr. Altaf Stationwala, Richard Tam, our VP, Amir Sohaili, our department chief, Dr. Dissett, and current chief, Dr. Evans, and all the pathologists, the lab management, and our clinical services director, Tim Serjanius, and our lab managers are highly skilled PAs, because without their help, assistance, proper sectioning, this wouldn't have been possible, and our dedicated histotechnologists. Of course, last but not the least, our LIS system, it has to be very strong, an IT support system, which has been on our side throughout, and our vendors, Philip and Epic, which is our LIS system. These are my references. Thank you very much for having me over here. It was a pleasure to deliver my talk. Thank you.
Thank you, Dr. Memon. It was a phenomenal presentation, very beautiful presentation.
Thank you so much. Thank you.
Yeah. So do we have any questions from the audience? Dr. Trevor, I can see you have raised your hand. Your question, please.
Yes, hello, Dr. Ma. Wonderful presentation. I just had a question with regard to, you mentioned validating within your hospital. Do you believe that that's something that each hospital will have to do to sort of validate the digital pathology for their particular needs?
Right.
Yeah.
So the validation is institution specific. So basically, as I said in my talk, it's not one size fits for all. So just we have to optimize, but these are the steps that we took. It's not written in stone that you have to take all these, but these are the important steps that are required for each organization. If you're thinking to go digital, then these are the steps that should be taken. We use the College of American Pathologists Clinical Practice Guideline, best practice recommendation, and good statements, and we follow through that. So
great, thank you. And then also with respect to the AI algorithms, are they being evaluated just as decision support tools, or what level of validation are they being considered for?
So basically what we are doing, since we have this digital pathology platform, so all we need is, you need all those cases first in the digital format. So we have that. So we have incorporated that, but right now our pathologists that have not went live to do those. So validation meant in terms of saying we just wanted to see the proper staining quality, proper everything. But our department chief, Dr. Andrew Evans, and he's a GU pathologist, and Dr. Ridamero, we are working on that with them. And basically, we have looked at the initial results and they're quite promising. So fingers crossed, that is our next goal, to implement that in our organization as well.
Great, thank you so much.
You're welcome.
Thank you, Dr. Memon.
Thank you, Dr.
Yeah, do we have any other questions from the audience? No questions. Thank you, Dr. Memon, for the detailed insight on digital pathology. It was really knowledgeable. Thank you so much.
Thank you so much. Thank you, everyone.
So next, we move on to our next speaker, Dr. Trevor DeMckey from USA. He is going to deliver a speech on the topic from one-to-many multiplexing biomarkers for spatial immune cell infiltrate in cancer immunotherapy and allograft rejection, best practices for computational pathology analysis. Dr. Trevor, over to you. Kindly share your presentation.
Yes, for sure. Thank you so much for the opportunity to present today. Just give me 1 second. Can you see my screen? So what I'll be talking, yes, wonderful. So what I'll be talking to you today about is, as mentioned, some efforts that we've been doing. So I'm jointly affiliated with, I'm an adjunct lecturer at the University of Toronto, and then I'm also starting a company called Pathomics that I'll discuss a bit later, where we're really trying to focus on best practices for multiplex image analysis. So what we'll discuss is basically briefly some challenges and opportunities in drug development, why we're doing this work, particularly in cancer immunotherapy, some methodological aspects of how to analyze and interpret this data, importance of quality control in this process, and then some examples interspersed from cancer immunotherapy, transplant rejection, multiple sclerosis, other immune aspects. And this actually dovetails quite nicely with Dr. Manon's presentation, in that I very much agree that validation is a very important part of looking at these tools. So just as a bit of background, let me see if I can hide the meeting controls so you can see the full screen. I did my PhD at MIT, and also was part of the Edwin Steele Laboratory. That's part of Mass General Hospital and Harvard Medical School, under the supervision of Dr. Rakesh Jain. And when there, it was quite interesting because it was the merger of engineering principles, understanding kind of the root cause of certain things with understanding of biological sciences, and then looking at the medical applications of technologies that are being developed. So the sorts of things that we did there was to, for example, we built a customized multiphoton microscope for intravital imaging. We use that to view drug transport within the tumors themselves, understand a little bit about the biology of drug and gene transport within tumors. In this case, a viral vector that was being injected into the tumors. And using that knowledge, we could design better treatments. So when we were treating animals with these viruses, we saw that the viruses couldn't penetrate into collagenous areas. So if we treated with collagenase, we could get better penetration of the virus, better therapy at the end. So, and I believe these viruses are now in clinical trials for use in humans. So, historically, when you're doing preclinical testing of drugs prior to bringing them into humans, you would test them in animal models. Whereas maybe 20 years ago, we were looking at the tumor as kind of just a black box where we're just looking at tumor regression and survival. Do the animals survive or not? Does the tumor grow or shrink? This doesn't give you a lot of information about what's happening in terms of the actual therapy. And so there's been both the development of better models, either tumors derived from patients that are grown in mice, or genetically modified mice, where there's an intact immune system with mouse tumors. Those are a lot better for drug testing. And then combined with that, newer types of imaging modalities that you can use on those animals gives you a lot more insight into the drug function, mechanisms of resistance, and can potentially help you tailor therapy to particular subsets of patients. So this is particularly important because the drug development pipeline is very leaky, and it's very expensive to develop drugs nowadays, because you come in with 10,000 compounds, from a screening protocol, and you need to get down to one drug at the end of this. And so there's a lot of testing that, if we can figure out which drugs are going to do better earlier in the pipeline, it's going to speed up the process and be able to get better results out. And we can do that with better preclinical testing methods, including imaging and pathology. And then bringing certain, potentially we use multiplexing when you're initially trying to find out which biomarkers is important. And then you could identify a biomarker that you might follow along with the drug through clinical trials into clinical implementation. There's a couple examples of this already in terms of HER2 staining and PD-L1 staining that are routinely used nowadays, or matched with HER2s, matched with Herceptin, for example. In addition, for tumor immunotherapy, it's very important to know which immune cells are present in the tumor and where are they located. So, and there are a spectrum from inflamed tumors where there's already T cells and B cells present within the tumor, to immune excluded tumors where there's a lot of immune cells at the edge, but none at the center, through completely immune desert tumors where there's no immune cells anywhere. And this is very important to know prior to giving your immunotherapy, because the inflamed tumors might respond a lot better because the cells are there. In addition, there's a whole bunch of markers and interactions between the T cells, the dendritic cells, the macrophages, and the tumor cells within the tumor. And knowledge of these interactions has actually led to breakthrough new therapies of Keytruda and others. Basic immunology research is actually key to finding out what these targets are and how to use them, such that Genentech VP said fundamental knowledge of biology is actually what's driving the pharmaceutical industry nowadays. How do we know whether a tumor is responsive or not? You can monitor with a bunch of different techniques shown here. I'll focus on the one at the bottom for the purposes of today, which is multicolor IHC. That's where you can stain for different biomarkers, see where they are, as mentioned previously. So we've actually formed a council together with a number of different practitioners, both in academia, in pharma, and the NIH. We had our initial meeting at the Society for Immunotherapy conference, and the main goal of this consortium is kind of how do we move multiplex staining closer to clinical practice, just because there's a lot more complexity, both in terms of staining, etc. We call ourselves the JEDIs, so Joint Effort to Develop Immunofluorescence Standards. We've done a number of things, including we've had a series of presentations and panel discussions that was hosted by Akoya in the Pathologist magazine. I believe those are available online. You can view them, and we talk about anything from panel design through imaging, through staining, and then subsequent analysis. There are also two calls for articles on the Frontiers website. So the Frontiers is a journal where we're looking at multiplex, the potential and promise for clinical application. And I'm one of the editors there, and it's actually, I believe there's still calls for papers to be submitted. And really, what we do in a nutshell is look at what are the challenges in the next 10 years to overcome with respect to image analysis. And there's a whole bunch that I won't necessarily go into, but this spurred me to think about, well, maybe one thing that's missing right now is sort of a repository of useful open source tools and data sets for computational pathology and for multiplex analysis. So I'm in the process of setting that up. The website is shown here, where basically collecting open source tools that are already available and making them available to on the website for anyone to be able to use and download. And so that's one aspect of what we're doing with Pathomics. Getting into the methodology of what we do. We're actually borrowing a lot of techniques that were initially used for kind of satellite imagery and cartography. So how would you tell what's in this image, for example? We can tell easily, but a computer doesn't necessarily know. So what the computer does is one approach is to analyze the pixels with respect to their neighbors, group pixels together into superpixels, then use some sort of classification and training to identify your trees, your roads, your buildings, etc. And so we can apply the same process to tissue. Here's a multiplex image. And what we can do is we can first identify where the nuclei are from the nuclear counterstain, and then we can find perhaps the membranes from membrane stain, and then we can look at the preponderance of a biomarker of interest to classify into negative, low, medium, high for those classes. So why we do this? One of the approaches, as mentioned, is for example, counting. Counting the number of Ki67 positive cells here is a tedious task. But we can use the combination of the counterstain and the immune marker to along with pathologist guided, of course, thresholding to say what's low, what's medium, and what's high, to get a count out of the tissue. And the advantage here is that the computer can do this count across a much larger area and give you better statistical outputs. But this has to be taken with a grain of salt. Computational methods, particularly for cellular segmentation, are never perfect. This is just one example where we were doing some analysis when I was at the hospital looking at transgenic mice that were developing tumors within the lung. Our initial machine learning output said, oh, this is all tumor. But when we went back and looked closely, the machine learning was getting confused between regions of blood pooling and the actual tumor cells themselves. So we had to go in and manually QC out the blood regions to identify truly the amount of tumor that was present. So, really there are certain advantages that pathologists have. They can very accurately, identify specific architectures for a wide variety of tissues. But the challenges pathologists have is counting cells is not really a very effective use of their time, but counting cells is something that algorithms can do very well. So, combining the best parts of the algorithms, the best parts of what pathologists are doing, you can get better results out. This has actually even been shown in presentations previously. So one way to approach, using pathologist guidance is to, for example, take this original image here, and here's an initial segmentation. So, is this doing a good job or not? It's hard to tell. But one way we can approach this is to do some blinded cell counts, just as you would count normally. You drop a pin wherever you believe there to be a tumor cell or a stromal cell. Tumors in purple, stromal cells in yellow. And then what we can do is we can now compare what the machine is telling us is present versus what's actually present. And if you look closely, you can see regions where we've identified a cell to be present that are missing. There's regions where there's multiple cells when there's only one dot. And so you can look at under and over segmentation, you can get some quantitative outputs that can tell you whether the algorithm is performing well or not. And so we've done this. So this is work done with pathologist Dr. Susan Doan, which I believe is published now, but we took breast cancer TMAs, stained for Ki67, and we separated out the tumor from the stroma. And then within the tumor region specifically, we counted, again, the presence of negative or positive cells. And we could see a correlation between the automated counts and the manual counts that, and it was better doing it this way than using a positive pixel count analysis, let's say. So we're able to validate that we can validate that the numbers that are coming out are accurate according to manual counts. We've extended this to working on multiple different biomarkers. This was in a phase 2 clinical trial. This was work actually done at the hospital in collaboration with Alimentiv, which is a CRO, and we had to separate the lamina propria from the epithelium, and specifically within the lamina propria, count the number of immune cells that were present, or for the different markers that were stained. What we did was to, again, manually validate on a small region of interest across all of these, and see that the ratio of the manual to automated counts was close to 1, or it's 80% to 120% of what the manual counts were telling us, and worked fairly well, except for very crowded cells. We could have some over segmentation, so we're over counting a little bit the automated relative to the manual, but nevertheless we could we could understand what's happening in these biopsies with respect to the different immune cell populations. And this was in the context of Crohn's disease, understand how much immune cells were present in the different patient subsets. So what we've done over time is to develop sort of a generalized analysis pipeline for being able to take IHC images and convert them into data. So we start out with a number of individual markers. We can actually align those markers together and create a virtual multiplex image where you can see the relationships between different stained regions. Then we use stain separation. So we separate the blue from the brown counterstain. We use the blue hematoxylin to identify where the cells are. Then there's a number of potential things you could do. You could classify those cells, put into shape, into tumor or other cell types, and finally get numbers and quantitative readouts out. But it's very important to make sure, as I mentioned, to do the manual counts, compare it back to what the machine is telling you, and if there's a discrepancy, go back through and adjust what's happening, because any one of these steps, if there's imperfect cell stain separation, there's imperfect segmentation, that's going to affect all of the downstream steps. So it's important to have an integrated workflow that will allow you to be able to do these sorts of validation methods effectively. So as mentioned, for immunohistochemistry, advantages are that it's used routinely in the clinic. It's very reproducible in terms of staining. However, as mentioned, it's generally single marker, unless you use chromogens. And so you have to identify cell types by morphology. You can't use a stain to identify a cell type. And this is just another example that out of work that we worked on in collaboration with OICR, the cancer research, where serial sections were stained for a number of different biomarkers, and then you can see the proportion. Now, these aren't the same cells; these are, of course, adjacent serial sections. So, but you can still see, what the makeup is of this lymphocytic infiltrate, for example. And this was used, our quantitative analysis was used for the CD8, for counting the CD8 cells. However, PD-L1 is a lot more complicated to assess because it's on the membrane. So after trying to segment the PD-L1, we ended up just doing the scoring manually. But the CD8 scoring we were able to do via quantitative analysis, and looking at this in versus mutational signatures in pancreatic cancer, we could identify different immune subtypes that correlated with increased immune activity. And this was a publication in 2017. So as mentioned, the immune system is quite complex. There's a number of different markers that relate to the individual cells. And, in an H&E, the best you can do is just tell, is it a lymphocyte or not, right? But you don't know, is it a T cell, is it a B cell? You need to have the immunostains to be able to do that. So this is a reason to use immunofluorescence or multiplex analysis, because you can start to stain the same cell type, the same cell for different markers, and understand what's happening there. The disadvantages, so the advantage is co-localization, disadvantage is complexity, in terms of technical challenges in staining and acquisition, secondary antibody cross-reactivity you have to worry about, and other challenges, but it still provides useful data. So this was an example that we did with Dr. Mingyali Wu's group. He's at University Health Network in Toronto, and we stained for the presence of DAPI and either a B cell marker or a T cell marker in mice that had undergone lung transplants. And so they're very talented surgeons that can do a mouse lung transplant. And here's an example of the transplanted lung, where you can see that if you transplant the lungs in this knockout model, there's a lot of immune infiltrate and rejection. And so here's a zoom in where you can see the individual cells that are present. And in this case, there's a lot of positive cells. And so when we count those cells, we can see that this knockout mouse has increased amounts of both T cells and B cells present within the lung. And so this indicates that this might be an interesting target for immune applications in transplant. Thinking about another advantage we have when we're doing immunostaining as opposed to other methods, say flow cytometry, is that we also have a lot of interesting spatial information present in these images. And the importance of spatial information, spatial biology in cancer has been known for many, many years. So this is a seminal paper in 1955 where they looked at the histological structure of lung cancers and noted that that there's a blood vessel in the center of this image, and there's only viable cancer cells can only live about 100 microns away from the closest blood vessel until they start to die. So all of this is necrosis, and the viable tumor is here, and the stroma where the blood vessels are present is in the center. They used this tool called a planimeter to understand this, but we can use quantitative analysis. So I was able to extract the images from this 1955 paper, segment it into stroma, tumor, and necrosis, and then perform a distance analysis and see that indeed, when you the further away you get from the stromal lesions, you get decreased tumor area fraction and increasing necrosis. They did all of this in 1955, and they were even able to estimate the distance by looking at the diffusion coefficient of oxygen and figuring the metabolic consumption of oxygen by those cells. So really fascinating work, but we can go back and reassess this. And then the work of Mr. Mark Zaidi, shown here. He's a PhD student that I was helping to co-supervise at the University of Toronto. What he's done is to now stain preclinical mouse tumors with hypoxia markers. We can, again, look at regions of blood vessels, regions of tumor and necrosis, and recapitulate this graph where you can see the further away you get from a perfused blood vessel, the less viable tissue is present, the more necrosis is present. But more importantly, what we can see in the middle is that there's a region of hypoxic cells that are low oxygen but still alive. And we can turn this data into something that looks like a flow cytometry plot, so tissue cytometry, but we can also look at distance relationships. So as we go further away from perfused blood vessels, we see the amount of hypoxia goes up, and the amount of proliferation goes down. And this was a publication in Frontiers of Bioengineering. This is very important clinically because the hypoxic tumor cells are going to be poorly proliferating. So therapeutic agents that target proliferation are not going to work as well on those hypoxic cells, and radiation is going to work as well because there's less oxygen to generate the free radicals to do the DNA damage. So there's a reason for doing this work, is to understand the relationships that are happening. From immunofluorescence, the challenge is there's only so many stains you can stain for at once. There are also newer technologies that are coming out that allow you to do, up to 30 markers on one slide. These are very highly quantitative, but the disadvantage is the increased complexity in terms of how to analyze these and what to do. So one of the technologies is called imaging mass cytometry. That's where you take antibodies and you label them with heavy metals, and then run the heavy metals through a mass spectrometer, and you can get a number of different channels that all relate to the same image, the same tissue, but show all of the different biomarkers that are present. So we've developed a IMC analysis pipeline that mirrors what we do with Brightfield, with the same sort of caveat that you need to make sure that you validate the techniques that you're using against your eyeballs and make sure that the numbers make sense. But being able to stain this many markers opens up a number of different applications. So here's an example where all of these are different views of the same tissue, just showing different markers that are present. So we could take, for example, alpha SMA and collagen to identify where the stromal regions were, and then we could look at the presence of E-cadherin to identify, or other cellular markers to identify where the tumor is, where the stroma is, and then where there's any lumens or holes present. Once we've done this, we can segment the nuclei with a nuclear stain, and then look at the presence of each biomarker on a cell-by-cell basis. One of the interesting things was that these tumors were treated with cisplatin. Platinum shows up in the right mass range to be able to be detected directly. And what we noticed was that most of this cisplatin ended up in the stroma, not in the tumor cells, but in the collagen surrounding the tumor. And we could quantify this. And so this potentially is bad because you're not getting the drug to the tumor cells that need to collect it. But it also is interesting because potentially you could take a skin biopsy of a patient, measure the amount of platinum that's present, and have some understanding of how much platinum is getting into the is actually getting to the tissues that you need it to go to. So as mentioned, oh sorry, I was going backwards. As mentioned, in addition to understanding these things, there's spatial information present in this image as well. So we can perform the same sort of distance bin approach, look at distance to the hypoxic region, distance away from regions of stroma where the blood vessels are present. And we can, once again, just as we saw with immunofluorescence, we can see as you go further away from these stromal regions, the amount of hypoxia goes up and the amount of proliferation goes down. But now we have a number of other markers we can look at. And so this becomes a very useful tool to really understand, distance relationships for multiple different markers all together at once. So we've applied this sort of approach to another imaging mass cytometry data set. This was work with Dr. Jen Gomerman, who's an immunologist at the University of Toronto, and she was studying multiple sclerosis. So in multiple sclerosis, there's normal appearing white matter, and then there's different types of active lesions where the immune system is attacking the myelin. And in order to do this analysis, we ran into some challenges. So when we segment the individual cells, this is a T cell marker in red and B cell marker in green. Sometimes we get cells that have the presence of both markers present in the tissue, just because the cells are very close to one another. And when we look at, the T cell marker and B cell marker, we see that we have a lot of overlap. So it's very hard to tell the two cell types apart. Our approach to overcoming that problem is use the biology to help guide the segmentation. So first we separate T helper from T cytotoxic cells using either CD3 or CD8 or CD4. Then we can separate the T cells from the B cells using B cell markers, and then we can identify the rest of the cell types. And doing it this way, we could get those individual cells separated from one another. And then, of course, we went back and validated that the cells that we identified were valid. But what we get out at the end is something that looks like this. So there's a whole bunch of different cells present in this image. There's also blood vessels. And so we have blood vessel distance shown in green, and then the different immune cells present. And this actually comes out as a heat map. So each of these columns is a different type of lesion present within the brain of this autopsy, where we could see For example, this activated lesions showing up in this column here have a high preponderance of a number of different immune cell types of interest. And then we can also look at where are each of these cell types relative to the closest blood vessel. And in the activated lesions, the cells are a lot closer to the blood vessel. So what that's saying is that there's actually active, in these activated lesions, there's active cells that are leaving the blood vessel, going into the tissue and causing the damage that's being seen. So quality control, again, is very important. I always say, what's the gold standard for knowing where a cell is? It's your eyes. You can look at a tissue and you can drop points that identify where the individual cells are. And so if we drop those points and we record the X and Y locations of each of those points, we can then start to compare the presence of a marker that says this is a cell with whether or not a cell is present there in the segmentation. And what we can show is that anything that's green here, green is good. So that's a one-to-one correspondence between a point and where we believe the cell to be. Red are under-segmented cells, so there's multiple cells present in this region right here, because we've marked 2, for example, but the computer says there's only 1 cell there. And then blue is over-segmented cells, so there's the computer saying there's a cell there when we didn't specify that there's a cell there. So when we do this, we can then start to quantify how many cells are there relative to the percent that are predicted from manual counts, and we can validate this technique. So this is a paper that we're putting together with Dr. J.C. Villas-Boas, who's a clinician at the Mayo Clinic, and we call it looped optimization guided by human annotation and machine learning. So it's what we can do is we can take some ground truth annotations, small regions where we identify all of the cell types. We then use the computational tools to identify, to develop a segmentation tool, and then we measure the accuracy directly against those. The advantage here is that now we can use this QC method, apply it to multiple different AI or ML segmentation methods simultaneously, and see where we are with respect to which one's performing the best. So, and then when we do this for the different cell types, we see that, we can identify the T cells, the CD8 positive T cells from the other compartments, and each color here is a different type of cell. So what this allows us to do is to start to set thresholds for what's negative and positive for each of the individual markers in order to, and in a way that's quantitatively accurate, and in a way that also recapitulates. And so this code that went into identifying where these cell types were is actually on our GitHub in a way that people can view it and use it towards their own applications. And so that's the advantage of open source, which we're a big proponent of. So just to conclude, there's, if you think about what commercial analysis solutions are available, there's a range of functionality. You can have a lot of features or less, or you can have very easy to use systems or quite difficult to use systems. And there's a number of different tools available in the market for this, both commercial tools as well as open source tools. What we're planning to do at Pathomics is, as I mentioned, collect all of these open source tools together, put it up on our website in a way that anyone can view it, download it, and use it. But in addition, what we're offering is expertise. So if you need help in doing this, we can provide that help in a consultative basis for a fee. So in conclusion, counting cells is quite tedious, can be challenging to do accurately. Image analysis methods make high throughput quantification possible for cells. There's a very strong need in immuno-oncology to move towards multiplex staining, but tissue level pathological assessment combined with these multiplex methods and with quantitation can give single cell results. And of course, quality control of segmentation and classification is very important. So thank you very much for your attention. I'd like to thank all of our collaborators over the years and funding sources. This couldn't have been done without a wonderful team of students, including Mark, who's working with me on Pythonics. This is my contact information, and yeah, happy to take questions. Thank you.
Thank you, Dr. Trevor, for your wonderful session and such informative presentation. Do we have any question from the audience, from the listeners? Any questions, please? Any questions? Sir, I would like to ask, is there any limitation of the study which you have done?
It's a good question. I think there's always pros and cons to each approach, right? So serial sections with immunofluorescence markers, IHC markers, are going to be a lot easier for pathologists to interpret than a multiplex image where there's a bunch of different cell types there. But the downside of serial sections is that you don't always get the same cell. You might get lucky and cut a cell in half, so you have one on one half, one on the other. But in general, it's a different population of cells you're looking at. So I would say the main reason to use multiplex as opposed to single color is if you need to know that that marker is present on the same exact cell. I think that's, yeah.
Thank you, sir. Thank you for sharing your expertise. Thank you so much. Now,
thanks.
Now we move on to our next speaker, but unfortunately he is not available. So he will be available in a bit. Okay, once he is available, we will resume shortly. So please stay online. So our next speaker, Dr. Emil Selmo from UK. Are you available? Are you available? I guess he's not. Then moving on to our next keynote speaker, Dr. Radhakrishnan from UK. Are you available? I guess he's also not available. Then Dr. Jamie Everett from USA. Dr. Jamie. Dr. Lubab Al-Qureshi from USA. Please respond if you are available online. Or Dr. Monica from USA. Dr. Fatima Tasneem from USA. Anyone? Are you available? As all the speakers are not available online, we come to an end to this session. I thank you all for attending the session, and it was really helpful, and I was really pleased to hear from all your experiences and expertise. And overall, it was a very great opportunity to host you all. And I'm really thankful to all the organizers for conducting such a smooth and good session. I just wish to meet you all in future. Best wishes and thank you all. And we come to an end to this session. Thank you.